Honorable members, MEC and the department, I've just been notified that we do have a quorum. So I would like to officially declare the meeting open and thank everyone for their attendance. I would like to welcome the MEC and the acting HOD, officials of the department to our meeting. May we just observe a moment of silence, meditation, or prayer before we start? Thank you. Honorable members and MEC and department, we are here with the agenda before us. Are there any apologies from honorable members?
Thank you, Chairperson. We've got an apology from Honorable Tele, Honorable Biel, and Honorable Mkhize. They are on the way. Thank you.
Are they all on their way? Or is Honorable Tele?
It's Honorable Tele. She's not coming. She's got a breakdown. But Honorable Mkhize and Biel, they are on the way.
So they're coming late?
They are coming, yes.
That's because of the clash. Okay. So can we put those apologies to the honorable members? Can I have a mover to accept those apologies? Honorable Mavimbela moves. Honorable De Boer seconds. Please then ensure that if any honorable member has not apologized, then those will be recorded as absent without apologies. Thank you very much. Yes. We have two honorable members online. So we have two honorable members online, and then the ones present, that's how the quorum is then formed. Welcome to the meeting, Honorable Kwanyana. We will then move to the constitution of the meeting. Can our legal advisor, for the record, just let us know whether we may proceed?
Thank you, Chair. We may proceed. We are constituted. Thank you
very much. May I have a mover for the adoption of the agenda? Honorable Mavimbela moves for the record. Can I have it on the record?
Thank you very much, Chair. I move for the adoption of the agenda.
Honorable De Boer.
Thank you, Chair. I second it.
So moved and seconded, and therefore adopted as is. We will move to the next item, number 5, and those are the remarks by the Honorable MEC. Honorable MEC, over to you.
Thank you very much, Chair. Good afternoon to you. Good afternoon to the honorable members, acting HOD and the management of the department, and all the colleagues from the legislature. Chair, I'll try not to be long because I think the 3 presentations that we have will require a bit of attention from the members. So I'll just speak to about 2 or 3 items that I'd like to talk to. We were fortunate. We had a very busy week last week, Chair. We were visited by the National Portfolio Committee of Health. It was a very fruitful session, a session that started on Monday. Well, on Monday we had TP Day, actually. On Monday we had TP Day with the hosting with the Deputy President, a very good program in itself because it started a week before that with leaders of the civil society in the province and engaging on a number of programs, engaging communities. So on Monday we had a TP Day that was hosted by the Deputy President, and it was the national one. It went very, very well. It was in Ugu district. We then had a portfolio committee starting from Tuesday up until Friday. The National Portfolio Committee had indeed visited a number of facilities. They focused mainly on Ugu and eThekwini, and while they visited facilities, Chair, or while they visited hospitals, I do believe that their focus was also mostly on mortuaries because I think the national chairperson has a particular interest in that regard. No, he does. So they did visit a number of our mortuaries, and I think that visit was quite fruitful because they were able to bring up a number of issues, and we're also given an opportunity to engage with them. And where they are supposed to raise the matters with National, we're able to say to them it is their space and it is them who must actually champion some of those areas. The biggest issue that we had a discussion on, and we presented ourselves to the committee, was the matter of bodies, unclaimed bodies that we have in the department. I must say, Chair, there has been great improvement from October last year to date. And this is as a result of our engagement with the commissioner, both at a provincial level and with SAPS at a level of national. We have unclaimed bodies, Chair, in our medical legal mortuaries. And the point that we needed to emphasize with the members was that, well, while the bodies are in our facilities, but in essence, we as the Department of Health are operating as a storage area because SAPS are the ones who open a case, who investigate, close the case, and once they've closed the case, only then can we dispose of the body or can we engage the municipality on a purpose bearer if it's necessary for us to do so. We have found that in the previous years, we had a huge number of bodies that were unclaimed. And the department itself kept on engaging with different SAPS officials at different levels, and not much movement was happening until the acting HOD and was a DDG at the time engaged with the police at a provincial level, and they elevated the matter to national to say, we are now finding ourselves with trays that we're unable to utilize because you, as the SAPS, have not concluded your cases. And as a result, you are frustrating our own process. We find ourselves with a lot of bodies. Some bodies had been in our facilities for 4 or 5 years, and it's something that is a problem. In fact, we realized this during COVID, during the floods, when we needed trays and we're planning to say what is it that we are going to do, and we're realizing that no, actually we have quite a number of bodies that were still with us unclaimed and had been there for a number of years, but SAPS was not coming to the party. So as of October last year, Mrs. Msimang started having engagements with the national SAPS and her national counterparts, and they put a system in place to say what is it that's going to be done to ensure that we clear the bodies that we have. So around before October, we had close to 1,600 bodies that were unclaimed in our facilities. But as of today, we have about 620 or 630 bodies that have actually been, the others have been processed. We now just have about 600 in our facilities. While Chairperson, that is still a big number, but when you consider where we come from, we think there's been some serious improvement from October to now. So we will continue with that kind of work. We'll continue with the approach that they have implemented. And this is the presentation that we also gave to the National Portfolio Committee. Of course, they believe that we must be able to push the SAPS, and we agree that we should push them. But, Chair, where you can only push and you don't really have authority on the matter, it does become a bit of a challenge. However, I think the strategy that we've started implementing is working, and Mrs. Msimang is going to continue to strengthen that particular strategy. Chair, you would remember that the Minister of Finance reported that there will be 800 doctors that are going to be employed in the country together with other health workers. We have been engaging with the national to say, have we been given an allocation? Because we were quite excited when that pronouncement was made. And, we'd be excited in the sense that we have unemployed doctors in the province, but we ourselves also have vacant posts that we want filled. So when that pronouncement was made, we were very, very excited. So we are still waiting for a report from National to say what is the allocation, because National has to then divide the 800 according to 9 provinces, and then they tell us what is our allocation. We are hoping that we will get a bigger chunk of the 800 because we are a bigger province compared to other provinces, but we've not then been given a proper assessment. So we are eagerly waiting that process. I'm raising a chair because I know that honorable members, wherever they are, they will be asked about this matter, and people will have interest, and the matter will be raised. The next point, Chair, is an issue of community health workers that I think I wanted to raise with the honorable members. NEHAU, as a union, Chair, took the Department of Health at a national level to court, to say the community health workers should be absorbed, and community workers should be part of the system, and so forth. And the decision that came out of that process was that the Department of Health is instructed to absorb community health workers. But that decision comes with no funding. We agree, we need community health workers, and they are part of the system. And without community health workers, you are unable to strengthen your primary health care, and this is what we want to work on. However, if you say absorb the 10,000 odd community health workers as a province now that we have, and you are not giving us funds, you are creating an even bigger burden and challenge for the province. So we then went back to national to say we agree with the decision and we are willing to implement. But how are you as National Health going to assist? Because this is a fund, this should come with funding. This mandate should come with funding. It cannot be an unfunded mandate. The Director General then issued a letter to us to say, as national, they are still exploring their avenues. They are exploring what is it that can be done, whether they are going to appeal the decision or they will have to find the funds. However, in the meantime, we are then instructed to give the community workers a contract of another year. So we have then written to the different community health workers to say we will renew their contracts by a year, and when we renew it by a year, then while national is working on whatever system that they are working on. I don't know, Chair, if they're going to be able to bring us what needs to be brought to the province, but I thought maybe members would be interested in this because this is another matter that community health workers have actually been fighting on for quite some time. If the matter gets to a clear resolution at some point, it will also assist us because we then are able to plan properly on what is it that we have. Right now, we have moved in terms of community health workers from 10,600 or so to about 9,300, but we are unable to employ new ones because we don't know what's happening. And you don't know whether you will be employing people on a one-year contract or you'll be employing people that must be then permanently employed. And when you employ someone permanently, the system is different because also even your budget allocation is different. But we really do want and hope that the department, national department, is going to finalize this matter once and for all. Chairperson, on our budget and that management is going to present, we decided that this time around, and they will give you, Chair, the different options that we looked at when we're budgeting. But we decided that it is in our best interest to fully fund all vacant posts that we have. All vacant posts that we have, we fully fund them. It was not done like that previously. But what that doesn't mean you are funding the posts that were vacated 2, 3 months, 4 months back. It just means the vacant posts that we have currently are all fully funded. Now, that assists us in a sense that we don't think that we have monies that we don't have. Because remember, compensation of employees are first, they are paid first anyway, whether you've budgeted for it or not. And you then end up with a budget that you say, I had actually budgeted 700,000 here, when actually it's 300,000 because the rest must go to COE. So we decided that let's actually fully fund that space so that we then are very clear on how much do we have left for COE. sorry, for goods and services. So that is how we have dealt with our budget this year, and that's how the management is going to present it. Finally, Chair, I want to indicate that we are very focused on strengthening our emergency services. We are very far now in dealing with the PPP, triple P, as we had presented to the portfolio committee. We believe that getting into a triple P for emergency services will assist us, because it will then give us the number of ambulances that are needed. But we are looking at different options. What are those options that are there? And once we've been able to clear those, we'll then present to the portfolio committee. Thank you very much, Chair. I think I will stop there.
Thank you very much, MEC, for your remarks. We generally don't open up the floor for discussion of the remarks, but there are some remarks that I would like to make. And then, in all fairness, if there are any members that do want to make some remarks, I'm sure you wouldn't mind taking a question or two. We were with you on World TB Day. You just didn't give us money. But anyway, it's fine. So thank you very much for that. And the province was indeed quite honored to have the launch of World TB Day in our province. One reason in particular being that we do indeed have, I should call it a co-burden, because together with the HIV burden that the province has, these two are inextricably related. I had a suggestion, and I think this is a good place to make it. In trying to get the testing done of the 5 million people that the minister and deputy president allowed, bring a truck to the next sitting of the legislature. You'll have 80 people done there, and then all the officials, so you can get. Yes, should test the legislature. It's a good idea, and then you can start with all your 150 department official staff that you have, 150,000 staff that you have in your department. That will also go a long way. I thank you for addressing the issue of the unclaimed bodies. It remains contentious. Some bodies going back to 2019, as you correctly say. We had, during our engagements at Northdale Hospital and at other facilities, it is in our resolutions, to have our own interaction with SAP's honorable members. So we'll find a slot. We're doing so many things and moving at a pace that we can't get slots. And then when we find an opportune time, then we get leaders of political parties tell us we can't have a meeting on that day because they are by-elections. But anyway, so that is just a side remark. But anyway, I think the important thing about the healthcare system is it does indeed need to be balanced. So whilst the focus is on doctors, there are pharmacists and everybody else, and now the court judgment by the on the Nehau matter. So these unfunded mandates create a problem for us as well, and I think it's a matter of grave concern that I don't think we can support as the legislature. Unfunded mandates on the province historically have created problems on the budget in manners that are unspeakable. So that is a big problem. Just to let you know, in terms of emergency services, the committee has, in the previous meeting, adopted as our focus intervention study emergency services. And you will see an item on our agenda, lower down on the agenda is the establishment of item number 10, Interlegislature Subcommittee. One of the directives that we will give that subcommittee once it's formed is to look into the particular area of emergency services as well. So it will be something that we want to focus on. So that's just on your comments. I don't know if there are any honorable members that wish to make any comments or have questions for the MEC. You may raise your hands. One, two honorable members. Okay, go for it, Don.
Thank you very much, Chair. Greetings to honorable members and Department of Health. MEC, I would love to take this opportunity to appreciate your report this morning. I think it's in some way alleviates anxiety, towards issues that has been raised, especially as the Honorable Chair is talking about the bodies in mortuary and all that. And we are very happy that there is something that is being done and that the department is proceeding to do as per the SAPS. And I think, Honorable Chairperson, we need really to support in terms of the SAPS, that they mustn't play around on our ground, so that we can be able to focus on what the department has to do. The other thing that I would love to again appreciate is that PPP arrangement. I hope that it is going to be done properly, without anything that is going to be a hindrance, when it comes to implementation. And I'm hoping that after the start maybe of that operation, we are going to see our people happy and we are going to be able to save more lives. And according to the unfunded mandates, they must stop doing that totally, but I'm sure maybe some ways need to be devised, because on the ground, there are a number of the maybe NGOs or something like that. Maybe some organizations, including your organizations, Honorable Chair, they need to take this, as also their burden, because community is for all of us. Thank you so much.
Thank you, Honourable Member. Before I get to Honourable Banyana, on the EMS, MEC, I want to suggest to yourselves that in your PPPs, I think one of the areas that you can immediately start with are what we refer to in some places as fixed rate transfers. So your emergency services are largely involved, and a classical example is between RK Khan's and Claywood Hospital. As the honourable members will know, or if you are not aware, there is a long ongoing project of public works at RK Khan. And as a result of which the wards that are affected cannot admit patients. So what they are doing is they're using the ambulances to taxi or ferry patients between RK Khan and Claywood Hospital. And that is using up a lot of resources. So when a person calls for an ambulance, ambulances are not available because they have been used to transport patients. That's not the job of the ambulances. The job of the ambulance is to attend to the emergencies. So I think if you find in your PPP arrangements a fixed rate transfer with a particular group of ambulances, then that in itself will free up your ambulances to actually get the work done that they're supposed to do. So it's a suggestion to you. Honorable Kwanyana, over to you. Yes, done.
Thank you, Chairperson. Greeting to you, to our MEC, my colleagues, officials, and support staff. Chairperson, I just want to congratulate the MEC for the work she has done with the National by visiting our mortuaries. Indeed, it was a fruitful visit, because after discovering that we have got so many bodies in the mortuary, some of them were taken out to be put somewhere where it is. But, Chairperson, when we have been visiting Fort Napier, no, not Fort Napier, our mortuaries, one mortuary we've been visited, we've discovered that the problem is with the municipality. They said they don't have place to bury these people. Now, I don't know what are we going to do, because if the municipality is not hands-on on this, or on the mortuaries, try to help them with these bodies, that means every day the mortuaries will pile up with the bodies. But I think as a department must try by all means maybe to engage with the municipality, or take some other options of how to eliminate this burden on the nurses in the mortuaries. Secondly, bese ngijabula ngithi 800 doctors Soweto. I was so embarrassed to hear that even these 800 doctors, uzocazwa, yet we need health workers like that in our province. Nurses, doctors, even the cleaners, we need them. There's nobody who's nothing in this department. But when it's going to be like this now, so kucela nje MEC ukuthi mhlambe kuquqa ngedwa bamnike inamba ethe xaxa kulabo dokotela abazoqashwa kuba sabadinga odokotela. Thank you, Chairperson.
Thank you, Honorable Member. On the doctors, I must say, MEC, I got a call last week from a doctor. She called me. She was crying. Her car was repossessed. She can't pay her rent. She's basically going to be on the street. She's unemployed. She's telling me, what must she do? I said, what do you want me to do? Calling me. We don't have money to employ you. What do you want me to do? Now, this is the condition of the doctor. And I did make a call to private company to say, look, here's a doctor, young graduate. She's sitting at home, crying, down and out, no parents, no support. Can you do something for this? We can use her as a nurse. Can you imagine that? We got nothing else for her, but at least she'll earn some money if she's prepared to come and work for us as a nurse. And I said, but she's not a nurse, she's a doctor. She's not registered to do nursing. And they said, well, we've got, maybe she can give our vaccines, inject the people. So I said, look, you can talk. Here's the number. But this is the situation. Anyway, over to you, MEC.
Thank you very much, Chair. I really appreciate the comments from both members. And I think we do take counsel from what the members are advising us to do so, including yourself, Chair. The only point I wanted to speak to was the issue of burial sites. In other municipalities, Chair, we just find ourselves struggling just with the issue of burial site. The department about 2 or 3 weeks ago was reporting to me that the one municipality where they have a challenge in is Umdoni municipality, where they've been told that the grave sites are not available and so forth. And there's evidence of the things that the department have done to try and engage the municipality. I then said to them, this means we must now elevate this matter to a political level. So I'm going to have a meeting myself with the mayor and the executive of Mdoni to say they need to come to the party. This is their responsibility. They can't, we can't keep bodies for 2 years just because they have not provided us with space to bury. But in other municipalities, Chair, you find that because of the different engagements, they then go back and they take their time. But sometimes when they come back to you, they then give you 50 spaces, and you find that we bury 50 people or 100 people all at once. And it happened recently, and as a result of that, someone, or we're told it was now being said in the media that no, we are clearing bodies because the portfolio committee is coming. However, what had happened was that only then did the municipality give us space. And when the municipality say we've got 50 or 100 graves for you, we don't think twice. We just take them there because it takes them a very long time to come back to us again to give us those areas. But it is true, we do have a challenge with municipalities, and we've decided that where we have serious problems, let's elevate it and make it a political issue with the political leadership of that municipality. Thank you, Chair.
Thank you, honorable members, for your comments, and MEC for your response. I think out of this, we can actually take a resolution of sorts on 2 things on this matter, honorable members. Can we then request a report from the department on the various engagements that they have had with municipalities, where the pressure areas are? And because we, in our own way, can make interventions by having our own resolutions, by interacting with those municipalities as well. Because remember, the resolutions that we take here become binding on them as well for the House. So we can definitely intervene and our assistance to the department in this area will be beneficial. So, are there any objections to that, honorable members? None. Thank you very much. You noted and send it. Fine. Thank you very much. Let's move on to the next item, and that is adoption of our minutes. May we have the minutes flighted, please? Honorable members, these minutes were circulated to you. So we're not going to read them word for word. We're just going to have a look at the page by page. If there's any errors that any honorable members identify, for the honorable members that were present, please do not hesitate to intervene at that point. There we go. Page 1, page 2. Page 2, I have a correction to make under item number 2 of apologies. Mr. Ninela, when you are recording the apologies, we always have somebody, and it has been the practice of the committee from the get-go, to note apologies received and those that are absent without apologies. It has always been our habit. And there's a particular reason we do this, honorable members, because the rules require us to ensure attendance at meetings, apologies at meetings, and substitutes where members are not able to attend. I don't see that in this minutes. I have also not seen it in other minutes, and I would appreciate that it is corrected in these minutes and that the final version is then circulated. But we'll accept it for now with that correction on its way, and all future minutes. Members absent without apologies must be noted. So under apologies, that's the only thing I would like to recommend. That can we move to page number 3. Members, can I go to page 4? Page 5. Page 6. Any corrections? Page 7. Page 8. That brings us to the end of those minutes. Any corrections? None. May I have a mover for the adoption of those minutes? Honorable De Boer moves. Can I have it for the record?
Thank you, Chair. I move for the adoption of the agenda of the minutes.
Honorable please.
I second the adoption.
So moved and adopted. Any matters arising? No matters arising. I just have one, item 7.3. This is for the department to note. Item 7.3 was your report on the emergency medical services. We have had a subsequent meeting. The minutes of that are still to be made available to us. Committee has withdrawn this report that you have presented to us, and we have decided to send it back to you with a note. It will be coming back to you. That is the only matter that is arising out of these minutes now. Honorable members, we then moving on to item number 7 and 7.1 in particular, third quarter report. MEC and acting HOD, the floor is now yours.
Thank you very much, Chair. I will hand over to the HOD who will indicate who will present on that aspect.
Thank you very much, Honorable Chair. Thank you very much to MEC, honorable members. Good afternoon. Good afternoon to colleagues. Honorable Chair, we are going to present our third quarter report, performance report which will be presented by Ms. Cindy Mabaso, and then it will be followed by the third quarter financial performance report that will be presented by the CFO. Thereafter, then we will present the other reports. Just to make a note, Honorable Chair, to say that in terms of our third quarter performance, honorable members and Chair will note that we are making steady progress in terms of the achievement of our targets, particularly on Program 2, which is district health services. District health services form the core of our health services because that is where we have our programs for communicable and non-communicable diseases. We have our primary health care services. We have our district health services. So the whole plan in terms of improving our health outcomes, reducing morbidity and mortality is centered mainly around the Program 2, where we are making progress on, particularly given that the fact that we did see some decline in performance during the years of COVID, but now we are steadily moving forward. Honorable members and Chair will also note that we have not made any progress to emergency medical services response times as per the comments that have been made and the report submitted, but there is a plan that we have in place and that we will present as MEC has alluded. So I will hand over to Ms. Mabaso to present the quarter 3 report. Thanks, Chair.
Thank you, HOD, and thank you, Chair. I don't know if it's okay to present from here, or would you like me to move to a... It's all right. Okay. Thank you very much. This is a presentation for our quarter 3 annual performance plan report. The presentation will cover an introduction, reporting process, departmental performance, each program performance, year-on-year performance, and the conclusion. In terms of introduction, Chair, the policy priorities set out in our departmental APP are aligned to the National Development Plan 2030, the medium-term strategic framework 2019 to 24, the provincial growth and development strategy 2030, other sector priorities, the burden of disease and the demand for services. Our impact is increased life expectancy, and it is supported by 3 outcomes, that is the universal health coverage, improved client experience of care, and reduced morbidity and mortality. The program of action is underpinned by a number of imperatives, and chief amongst these is improvement of people's health status, a culture of disease prevention, promoting healthy lifestyles, early disease screening and testing, as well as improving the quality of healthcare and access thereto. The reporting process follows an annual operational plan that is developed at various levels in the department, that is at district and provincial level. This tool is based directly on our annual performance plan, and as a result, it doubles up as a quarterly and annual reporting tool that then assesses performance directly against our objectives as a department. The key data source is still the District Health Information System and various other program systems. And the reporting follows the 8 programs, that is Program 1, Administration, 2, District Health Services, 3, Emergency Medical Services, which is your ambulance services, 4, Provincial Hospitals, 5, Tertiary and Central Hospitals, 6, Health Sciences and Training. However, we do not have any targets for this program on a quarterly basis. It's only annual targets. As a result, the quarterly report will not focus on Program 6 at this stage. Program 7, Healthcare Support Services, and 8, Health Facilities Management. In terms of overall departmental performance, on slide 9, we had a total of 69 performance indicators, and 53 of these have quarterly targets. However, Chairperson, we still do
monitor all 69 indicators on a quarterly basis. For the period October to December 2024, targets were met on 60.4% of indicators, and this is 32 indicators. This is an improvement from 54.8% achievement in Q3 of the previous financial year. On slide 10, the overall performance is depicted there for the department as well as each program, with program 1 at 50%, program 2 at 62.1%, program 3 at 0%, 4 at 71.4%, program 5 at 57.1%, program 7 at 100%, and program 8 at 50%. The next slide, Chairperson, I will not necessarily go through each and every line, but just basically shows the projection in terms of the likelihood to meet targets by the end of the financial year. On the next slide, we then look at individual program performance, starting with program 1 on slide 13. In terms of indicator percentage of hospitals implementing e-health beyond module 1, the department met the target and we were at 92.9% against the target of 76.2%. Percentage hospitals implementing e-health for the first time, we did not meet this target. Supplier invoices paid within 30 days, we were at 42.8% against the target of 96.2%. Proportion of expenditure paid to businesses owned by women, we were at 23.2% against the target of 14.8%. In terms of achievements, we did well with regards to module 1 of e-health system, as well as increased compliance by female business owners to competitive bid offers. Challenges that impacted the areas that we did not achieve, particularly the payment within 30 days, is the issues around the cash flow restrictions, thereby reducing the number of supply invoices that can be paid within 30 days. And interventions here, should additional funding allocation be availed, this would definitely assist in making payments on time. In terms of milestones reached to date regarding e-health system, 16,592 system users have been trained, 595 computing equipment distributed. KZN Health ICT requested Telkom SA to provide a plan to improve the internet and LAN or connectivity for the 42 hospitals that were targeting in this financial year. And this was submitted. There's been progress in terms of LAN and connectivity portion of the plan. However, the internet portion is still underway. There was also successful appointment of 256 interns currently assisting with scanning and digitalization of patient paper files. On slide 16, 11 administrators are employed to implement, train, and support the e-health system at the 42 hospitals. 45 modules have already been developed, and the system is integrated with various program systems within health, as listed there at the end of that slide 16, Chair. On the next slide, looking at program 2, district health services. In terms of indicator patient safety incidents, case closure rate at district health services, the department achieved 97.2% against the target of 97.9%. In terms of severity assessment code 1 incidents reported within 24 hours, we achieved 93.7% against a target of 100%. Key challenges impacting both indicators include vacant quality assurance coordinator posts and network challenges that impact management of patient safety incidents. And the interventions include that districts are continuing with weekly monitoring, review strategies to mitigate risk factors, and conduct support visits. On the next slide, in terms of sub-program HIV/AIDS, sexually transmitted infections and TB, regarding TB client treatment success rate, which we used to refer to as your TB cure rate, the department was at 75.8% against the target of 72.1%. In terms of multi-drug TB resistant success rate, we were at 68.6% against the target of 72%. In terms of extreme drug-resistant TB success rate, we're at 47.7% against the target of 55.6%. In terms of adult viral load suppressed rate, we were at 83% against a target of 95%. And for children, for the same indicator, we were at 55% against a target of 90%. In terms of HIV positive 15 to 24-year-olds, we were at 1.6% against the target of 1.8%. In terms of, on the next slide, TB loss to follow up, that is our defaulters, we were at 6.9% against the target of 9%. In terms of TB rifampicin resistant multi-drug, loss to follow up, we're at 15.3% against the target of 15%. TB extreme drug resistant loss to follow up, we're at 16.9% against the target of 22.2%. Adults remaining in care, that is for those that are on ARTs, we're at 68% against the target of 74%. And for children, same indicator, we were at 80.7% against the target of 79%. Overall, in terms of the areas where we performed well, improved linkage, as well as promotion of HIV prevention contributed to the good performance. Key challenges around this sub-program are the high death rate, which is associated with various comorbidities, as well as non-adherence and late presentation for treatment. The interventions to cover the challenges within this program include community awareness campaigns, implementation of the Bring Back 25% of patients, as well as orientation of new staff on linkage to care. On slide 22, sub-program maternal and child health. In terms of death rates, all the death rates, that is the neonatal death, the under 5-year deaths, the under 5 diarrhea case fatality rates, the pneumonia case fatality rate, under 5 malnutrition case fatality rate, as well as the stillbirth infertility rate. The department did well. All performances were below what was targeted. On slide 23, IUCD uptake, that is the intrauterine contraceptive device, which is a long-acting contraceptive device. The department achieved that. Deliveries 10 to 14 years in facility, the department was at 398 against the target of 474. And this is a proxy indicator for teenage or maybe rather child pregnancies. In terms of antenatal care, first visits before 20 weeks, we were at 79.1% against the target of 75%. Other postnatal visit within 6 days at 86.6% against the target of 73.6%. Infant PCR test positive around 6 months at 0.28% against the target of 1%. And this is a gauge of how much are we preventing mother-to-child HIV prevention. And KZN, the last time I checked, we were the best performing in the whole country. HIV test positive around 18 months rate, we were at 0.13% against the target of 1.5%. On the next slide, in terms of child and maternal health indicators, immunization under 1 year coverage, we were at 84.7% against the target of 95%, so we did not reach our target there. The same applies to measles second dose, 1 year coverage, we're at 89% against the target of 95%. In terms of cervical cancer screening coverage, we're at 67.9% against the target of 70%. Areas of good performance were as a result of implementation of the essential package of pediatric care, effective case management, multidisciplinary focus in KZN to reduce teenage pregnancy, implementation of new vertical transmission program guidelines on syphilis. Challenges exist around expanded program on immunization catch-up drives, which need to occur at all districts. And there were also patient factors such as barriers in accessing cervical cancer screening, and some of them were related to socioeconomic factors. There are also women who are not aware of how critical it is to actually do a pap smear, that is cervical cancer screening. So as a result, the department plans to implement catch-up drives, that is to improve the immunization coverage, expand screening services to more locations, including rural and underserved areas, as well as conduct public awareness campaigns to educate on, for example, your pap smear. On the next slide, it's sub-program disease prevention and control. The one indicator in this program was achieved as a result of training on mental health and substance abuse cascade and indicators. Under program 3, emergency medical services, we did not achieve the 2 indicators on response times, that is ambulance response times for both urban and rural areas. And the challenges in this program include our aged fleet, aged ambulances that often require repairs frequently, as a result, causing more downtime in terms of accessibility to ambulances. For the Q3 period, we also had a common challenge where most fleet repair and maintenance merchants are not operating due to the holiday season, and as a result, delaying the repairs of these vehicles as well. So interventions that the department is engaging on, we continue to engage fleet management service providers on an ongoing basis to avert some of these challenges. And the department issued 38 new ambulances and 2 rapid response vehicles to districts in December 2024. In terms of program 4, provincial hospitals, indicator patient safety incident case closure rates, we were at 99.5% against the target of 98.1%. Deaths in facility under 5 years, diarrhea deaths, pneumonia deaths for the same age group, as well as malnutrition deaths for the same age group, were all achieved. In terms of severity assessment code 1 incident reported within 24 hours, we were at 98.1% against the target of 100%. And in terms of reduced mortality and morbidity, we achieved 4,968 against the target of 5,025. And this will be for cervical cancer screening, sorry, Chair. And Chairperson, in terms of your PSI or patient safety incidents and severity assessment code 1 incidents, I will not dwell much in terms of the narratives here, as they've already been alluded to in the previous slide, but just to focus on the key areas for this program. Achievements were related to decreased number of preterm admissions, increased access to respiratory support, reduced healthcare associated infections, compliance to clinical management guidelines, and reduced in-facility deaths under 5 years. So basically, this was contributing to the good performance areas. Program 5, tertiary and central hospitals, indicator PSIs was 100%, against the target of 97.4. In terms of under 5 deaths, deaths in facility, diarrhea, and pneumonia were all achieved. However, severe acute malnutrition for this level of healthcare was not achieved. We were at 8 against the target of 5. In terms of severity assessment code 1 incidences reported within 24 hours, we were at 98.6 against the target of 100. In terms of cervical cancer screening, we were at 803 against the target of 1,110. Chairperson, particularly focusing on malnutrition, which also depicts issues around socio-economic status. At tertiary level, this is often determined by the clinical status or clinically determined. And in assessing these cases, it was discovered that there's a lot of complicated cases, and rightfully so, because at this level, that's the nature of the cases that are dealt with. However, it was also noted that there were comorbidities such as your cardiac conditions, cerebral palsy, and late diagnosis of HIV. The department continues to implement the integrated management of childhood illnesses program to ensure that we are able to identify cases early, refer them, and also manage them accordingly. In terms of Program 7, Healthcare Support Services, both tracer medicine stockout rates were achieved, and this was as a result of constant engaging of our pharmaceutical suppliers, stock management, as well as rationing of products with supply constraints to ensure that facilities were always covered with particularly tracer medicines. Program 8, Health Facilities Management, percentage of preventative maintenance expenditure was at 42.3% against the target of 48%, and the number of capital projects that were completed was at 35 against the target of 25. And achievement there was as a result of a lot more projects that were completed, such that even the annual target was achieved by the end of Q3. In terms of challenges, there were major breakdowns from power outages, particularly breakdowns of medical equipment, and there was also under expenditure on preventative maintenance as a result. The department continues to advocate for regular machinery and equipment servicing in order to avert these breakdowns. In terms of year-on-year performance, just having a look at from 2017-18 to 2023-24 financial years, we started off at 43%, increased slightly to 53%, and then dipped during the 3 years when there was COVID-19 pandemic response. And in 2023-24, the department incrementally improved in performance from each quarter and closed the financial year at 58%. We've noticed that there's been the same trend for the current financial year, current as in the reporting financial year 24-25. From each quarter, we have consistently improved, and we are hoping to close it off looking much better than the previous performance. In conclusion, Chair, the department plans to consistently improve the province's healthcare service delivery system by focusing on access, equity, efficiency, quality, and sustainability at various levels of healthcare. Programs are consistently reviewing strategies towards improving performance in all underperforming areas, and this includes integration of services for efficient resource utilization, as well as monitoring performance progress for all deliverables. Furthermore, Chair, the department will continue to solidify its partnerships with all relevant stakeholders, including social partners, to deliver quality healthcare. That is all, Chair. Thank you.
Thank you very much. Can we move on to the next presentation on the APP, and then the budget, and then we'll open the floor for discussions and resolutions.
Thank you, Chair. Mr. Jack Government, I will present on the APP. Finance Q3.
Yeah, the financial, these were the non-financials. So we want just finish everything, then we can go through. We just direct who you want to present.
Okay, so let me take the Q3 finance.
I'm just following the agenda as it was presented, but you can move on to the board.
Over to you, CFO.
Thank you, Chair. Honorable MEC, honorable members, acting HOD and colleagues, may I present financial performance reports, quarter 3 as at 31 December 2024. The content, we have overview of 2024-25 expenditure per program as at 31 December and per economic classification at 31 December. Then we have conditional grants at 31 December, all 2024. And then we have revenue also at 31 December. I would like to indicate that at 31 December, it's end of quarter 3. So what we call the norm or benchmark is 75% of the total spend and 75% of revenue. All things equal, that's where we should be, except where there's seasonality and delays. The projected overspending at 31 December is 3.7 billion. This has been reduced from what we had during quarter 1, where we're sitting at 4.7 billion. Currently, we are at 77.9%, where the norm should be 75%. Main pressure comes from cost of employees at 2.5 billion, and then the remaining 1.2 billion is related to goods and services. You realize that there is property-related payments, forensic investigations, consultants, airtime, ICT-related spend, medicines, medical supply, laboratory services, they are all sitting on overspend. Machinery and equipment project underspending due to planned deferment, where we then said we are going to defer procurement of non-critical equipment as part of our addressing projected overspend. And here we are behind by 102 million. Household projects and overspend of 30 million, mainly due to claims against the state. I'll then present expenditure per program. We had main appropriation of 53,796 million, actual spend 41,889 million. Actual spend as a percentage was sitting at 77.9%, represented by projected overspend 3.7 billion and projected total expenditure 57.5 billion as compared to 53.8 billion that was budgeted. That was appropriated to the department. I'll take this program 1 administration. Spending was at 152% due to outstanding NHLS journals, representing 1,078 million for other clinical programs, and is projected to overspend by 181 million, mainly on computer services, communication, cell phone, and audit costs, forensic investigations, and AG. Auditor General spend. Program 2, District Health Services, is projecting overspend of 2,039 million as follows. Compensation of employees as a result of 2024 wage agreement is already at 81%, and the overspend expected is 1.6 billion. Goods and services projecting an overspend 492 million, mainly property payments, medical supplies, medicines, as follows: property payments 314 million, medical supplies 72 million, and medicines 54 million. Program 3 EMS is at 62 million 920. It's 62 million overspent, attributed to cost of employees 17.8 million, and goods and services 29.3 million. Provincial hospital services is at 78.5%, projecting overspend of 995 million, mainly being cost of employees 750 million, goods and services 285 million. Program 5 Central Hospital Services at 76.9%, 219 million is cost of employees overspent due to the unfunded wage agreement from 2024 and the overspending on goods and services, 270 million. It's actually the overspend on goods and services mainly attributed to laboratory services, 139 million, medical supplies, 76 million, and the spending on property-related payments allocated to budget sitting at 73 million. Program 6, Health Sciences and Training, there's an underspending there due to non-filling of nurses' posts, 21 million underspent. Healthcare support services, overspent, we are at 83%, due to medicine trading account and outstanding medicine journals to facilities that are still going to happen. Health facilities management will project balanced outcome. However, the spending is at 65%. The budget's due to HFRG spending at 61%. Underspending is mainly due to late receipt of Department of Public Works invoices. Those are still going to come through and be generalized. And the delay is due to downtime of bus system and network issues. Goods and services is overspent due to accrued backlog of maintenance projects managed by Department of Public Works. Expenditure per economic classifications. Compensation of employees main appropriation 33,366,994,000. Actual spend is at 80%, 26,895,708,000. And there is an overspend projected at 2,575,000. Goods and services overspend is projected at 1,245,000,000, sitting at 76% right now. And from the main appropriation of 17,834, actual spend 13,597,000, and projected spend 19 billion, representing 1.2 billion spend. Interest on rent and land. Budget 534 million. Actual expenditure, apologies. Interest and rent on land. Main appropriation 534,000. Actual expenditure 7,219,000. Total projected expenditure 7,426,000. And projected over expenditure 6,892,000. This is now represented by transfers and subsidies. 779 million transfers and subsidies. Actual spend 410 million at 52%. Projected
Sorry to interrupt you. We don't want you to read line by line. Just give us the
okay. Transfers and subsidies.
All members are feeling cold. Directly on you.
It's open
On a lighter note, when you have a room full of politicians, there's generally a lot of hot air. So that's why. Yeah, maybe open the door. The other ones don't work. Okay. Yeah, sorry for the disruption, CFO. You may continue.
Thank you. To sum it up, projected overspend 3.7 billion. Conditional grants, we're expecting to spend 100%, 11,913 million. We're currently sitting at 65.28%, and then we're expecting to pick up the generalizing and get to 100%. The district health program grant at 62%, health facilities revitalization grant 61.6%, human resources and training grant 77.6%, national health insurance grant 83.2%, national tertiary services grant 73.5%, expanded Public Works Program Integrated Grant for Provinces, 100%. Social Sector Expanded Public Works Program Incentive Grant for Provinces, 69%. Revenue, we are projecting collection of 233 million. Actual collection at December 2024, 185 million, and under collection will be was at 48 million. What we are projecting now, we had a target of 359 million, and we're projecting under collection of 118 million, below that target. Third quarter revenue collection, there's a narration there. Then I'm going to say it's attributed, the 185 million is under collection. 185 million collected, under collection 118 is attributed to sale of goods and services other than capital was under collected. And then there's also fines, penalties, and forfeits collected, was also under collected. Interest, dividends, and rent on land over collected. Sale of capital assets under collected. Transactions in financial assets and liabilities under collected. Road Accident Fund, SAPS, COIDA, GEMS, Now, these are government-related parties were also under-collected from such. Projected end-of-year revenue collection, we're at 51.5% right now. And then this is 118 billion under collection against the target of 358 billion. Yes, said. May I then move on? Oh. There was Q3 financial performance.
Thank you, CFO. Madam Acting HOD, APP.
Thank you, Chair. We will now present the APP, to be presented by Mr. Jack Garnett. To then be followed by CFO presenting the 2025-2026 MTF budget. Thank you, Chair.
Thank you very much, HOD. Good afternoon to Honorable Chair, MEC, honorable members and colleagues. So I'll take you to slide 3 of the presentation. Just to reflect on the purpose, to present the 2025-26 APP for adoption by honorable members of the Health Portfolio Committee. Slide 4, and we just reflect on the process to develop the APP. On slide 5, we take you through the planning process map, which starts in July and ends in April. And just to note that we have submitted the strategic planning and performance plan to legislature as per the timelines, which are reflected in slides 6 and 7, as well as slide 8. On slide 9, we show you the structure of the APP, which talks to the mandate in terms of the constitutional mandate, policy mandates, and various policies and strategies for the 5-year period. We reflect on our new vision and mission, as well as list the performance information that we're going to target for the next financial year. Slide 10, unpack the constitutional mandate. Slide 11, we reflect on the guides for the content of the APP in terms of the NDP, the medium-term development plan, SONA, SOPA commitments, MEC's budget commitments, as well as cabinet quarter priorities. On slide 12, we just unpack further the MDDP priorities, as well as some of the discussions that has happened by the cabinet quarter. Slide 13, we note that the Department of Health responds to strategic priority 2 of the MTDP in terms of reducing poverty and tackling high cost of living, with a specific outcome of improving access to affordable and quality health care. But remember to note that we do respond as well as to priority 1, as well as strategic priority 3 when we report. On slide 14, we just note that we have 9 priorities that the department has come up with based on the various engagements that we've had internally as clusters, a strategic planning session, as well as input from the MTDP. So the priority 1 is to pursue the progressive achievement of universal health coverage, focusing on improvement of quality, safety, and access to health services. EMS will fall under this as well. Priority 2 is to strengthen mental health care service delivery in primary health care and community-based mental health services. Priority 3 is to reduce the high disease burden and stemming the tide of non-communicable diseases. Priority 4 is strengthening health promotion and prevention through engagement and empowerment of the community. Priority 5 is improving human resources for health. 6 is the execution of the infrastructure plan, as well as focusing on well-maintained facilities. 7 is improvement of public sector financial management systems and processes in the face of budget constraints. 8 is strengthening governance and leadership for oversight, accountability, and health system performance, and improving information and management at all levels. And item 9 is ensuring pandemic preparedness and response. This is largely to the disasters that we face in the province. In terms of the vision, the slight tweak on that, where we talk about a long and healthy life for all individuals and communities in KwaZulu-Natal. The same with the mission is to protect, promote, improve, and maintain the health of individuals and communities in the KwaZulu-Natal through integrated, multi-sectoral, sustainable, and comprehensive health systems at all levels. Then we note the core values the department has adopted. On slide 16, in terms of the impact, it is increased life expectancy at birth. Members will remember that we had two outcomes previously. We maintained three outcomes previously. We maintained the outcome improved client experience of care, as well as reduced morbidity and mortality. The other outcome that we had was universal health coverage that becomes a major output for the department rather than an outcome. On slide 18, we just explain the external environment that we operate in around the quadruple burden of disease, the emergent disease burden, as well as other health conditions that we have to manage. We reflect on the internal environment in terms of the service delivery platform, as well as the various outreach programs that we have to improve access. So we take you to slide 22, where we just list the number of indicators that we have in the slide 22 in the APP. And we note that some indicators have been standardized, coming from national as well as the MTDP. Various programs did not have standardized indicators, largely program 3, MS, program 6, 7, and 8, which we added as a province. So slide 23 and onwards gives the detail of the indicators that we want to measure in the APP. So the first one is around maintaining the unqualified audit outcomes. The second one is looking at capacitation in the districts in terms of managing contract units when we do implement that. We're targeting 4 of that. Program 2, we want 100% of our primary healthcare facilities to do surveys to measure patients' experience of care, whilst we look targeting 60,000 screening for grade R learners. We also want on slide 24 to have all our hospitals conduct surveys to assess patients' experience of care as well as implement interventions based on the results. On slide 25 and 26, we list the familiar indicators that you know of in terms of HIV and TB with the specific targets. On slide 27, we go further in terms of maternal, woman, and child's health, including nutrition, noting that we want to monitor couple-year protection. We want to reduce the child deliveries in terms of 10 to 14 years in the facility from the baseline of 610 to 537. Various increase in indicators for antenatal care, postnatal care, testing, infant first PCR testing at birth rate, as well as immunization coverage under 1. So 28, we continue with our vaccination program, as well as managing fertility rate based on the various conditions reflected, namely diarrhea, pneumonia, as well as malnutrition. And we want to see a progressive increase in our cervical cancer screening coverage. Slide 29, we reflect on indicators around for NCD, mainly malaria, mental disorders at primary health care, as well as ensuring that all of community health centers have at least one mental health provider appointed. On slide 30, we show progression in terms of our targets for response times in the urban areas, as well as response times in the rural areas. Slide 31 and 32, we are targeting survey rates at the various hospital types to ensure that all hospitals do conduct these surveys. Slide 33, we note the bursaries for first-year nursing students being at 240, whilst we're looking at targeting 240 employees to get bursaries. On slide 34, we show a slight decrease in terms of the stock out rates we're targeting for, both at the depot as well as at the health facilities. In slide 35, in terms of health facilities management, we've added a few additional indicators to show more detail, but we're still reporting on preventive maintenance. We want to see 40 projects completed for capital infrastructure, Chair will notice that in terms of the baseline for 2024, we're at 100. That is the way we defined projects previously. And now we kind of grouping projects together. For example, fencing, if we do 10 fencing projects and 10 clinics, we're grouping that as one fencing project. So that's why the numbers have decreased. We want to focus on maintenance in terms of a number of public health facilities. We're targeting 600 of that, whilst renovations, refurbishment, and rehab projects we'll be targeting 12. So that is the targets that we have for the various indicators, Chair. And with that, I think I just want to note and request that honourable members do adopt the 25-26 APP based on the presentation that's made. When you look at page 41 onwards, we give you a full list of indicators that we will be monitoring, which will include the indicators from the APP. Thanks, Chair. With that, I close the presentation. Thank you.
Thank you very much, sir. Well done to you in terms of using your time and getting through the APP. CFO, over to you for the presentation on the 25-26 budget. Can it be flighted?
Thank you, Honorable Chairperson, Honorable MEC and members, acting HOD colleagues. MTF budget hearings 25-26. This is starting today till end of March 2026. The budget is aligned to our strategy APP that's been delivered, and the Treasury guidelines, and is compliant with Treasury guidelines. SLAs implementing agents and grant frameworks, there's key assumptions. And then again, economic classifications programs, we have conditional grants, and we use scenario 1 if, and then stated why we use scenario 1 when compared to scenario 1 and 2. Budget aligned to APP. Impact and outcomes as departments, which are as follows: increase life expectancy at birth, improve client experience of care, reduce morbidity and mortality. Slide 4. Details of all major capital infrastructure expenditure planned for the current financial year starting today, and proposed rollout of this expenditure in the outer MTF years. This is now to 2028 March. The projects fall under the following nature of investments: renovation, refurbishments, rehabilitation, upgrades and additions, new or replacements. Key assumptions. We have not been able to provide funding for carry-through costs of the 2024 wage agreements. The department will continuously review the cost establishment to manage the number of posts in line with affordability of the MTF. Where feasible, CPI projections were used. Otherwise, medical-related items inflation is 2% above CPI. There is possibility of withdrawal of care. US donor funds will withdraw, and then there's an impact on departments' budget pressures. Provisional additional allocation of 28 billion is rounded off to 29 billion to the health sector over the MTEF. This is nationwide, so we are not sure yet what is attributed to KwaZulu-Natal Department of Health. Estimates summary a program. Medium-term estimates 25-26, 56.2 billion. Next year, 58.8 billion. 27-28, 61.6 billion. Broken down the program as follows. Administration 1.4 billion, district health services 28.8 billion, emergency medical services 1.9 billion, provincial hospital services 13.9 billion, central hospital health services 6.2 billion, health sciences and training 1.6 billion, healthcare support services 394 million, health facilities management 2 billion. Reprioritization of budget per program and economic classification. There was reprioritization and adjustment of budget largely at program level. There was reduction to program 6 due to department over budgeting for Cuban doctors programs, which has now been wrapped up. Then those funds were reprioritized to program 2 and 4 to address COE overspend. Program 2, district hospital services. There is movement between sub-programs related to correction of some of the state-aided institution allocation from community health clinic sub-programs to mental health function under community services sub-program. Movement across economic categories, goods and services decreased 413 million, with carried through being over budgeting for medicines, largely within district health programs grant. Transfer and subsidies, households were reduced by 46 million, with carried through being over budgeting for Cuban doctors program as mentioned before. Machinery and equipment reduced by 33 million, attributed to forced savings to address pressure, overspend pressure. And this was mainly dedicated to compensation of employees' shortages. Summary by economic summary of estimates by economic classifications. Compensation of employees 35,276 million, goods and services 17,810 million, provinces and municipalities, this is now transfers and subsidies 294 million, departmental agencies and accounts 26.8 million, non-profit institutions 64.8 million, households 405 million. Payments for capital assets 1.7 billion, broken down into buildings and other fixed structures 1,115 million, machinery and equipment 500 million. Conditional grants and infrastructure projects 12,179. broken down to district health programs grant 7.466 billion, health facilities revitalization grant 1.5 billion, national tertiary services grant 2.29 billion, 89 million national health insurance grant, and EPWP grant 27 million, 788 million HR human resources and training grant. Summary of provincial infrastructure payments and estimates by category. 20 existing infrastructure assets 1.1 billion 443 million, broken down into maintenance and repair, current 354 million, upgrades and additions, capital upgrades and additions 842 million, and refurbishment and rehabilitation 247. And then we have infrastructure leases 100 million, non-infrastructure 491 million. Scenario analysis for in-year implementation. We've embarked on scenario planning one, like I have explained. Assumption, fully funded warm bodies, excluding 2025 wage agreement, 2.5 billion, and also fully funded non-negotiable items, including CPI, and partially funded goods and services, the negotiable ones. All other economic classes remain the same. Budget allocation process per economic class. I've stated this before, but the biggest chunk goes to COE, 35.2 billion, goods and services split into non-negotiables, 14.7 billion, and negotiables, 3 billion. Buildings and other fixed structures, 1.4 billion. Provinces and municipalities, 308 million. Households, 395 million. Machinery equipment, 863 million. Please note the following rule for the environment. Powers vested upon the accounting officer to utilize saving in the amount appropriated under a main division within a vote towards the deferment of excess expenditure under another main division within the same vote, unless the relevant treasury directs otherwise, which is catered in provincial treasury in this case. The amount of a saving under a main division of a vote may be utilized in terms of subsection 1, not exceeding 8%. An accounting officer must within 7 days notify, report the particulars concerning the utilization of saving to the executive authority responsible for this department, as well as to relative treasurer. This is notification, not seeking concurrence or permission. This section does not authorize the utilization of a saving in an amount specifically appropriated for a purpose mentioned under main division within a vote, transferred to another institution, and appropriated for capital expenditure. Thank you.
Thank you very much, CFO. In this part of the presentation, I thought it was important for the CFO to read each of those amounts into the record because it's going to form part of a vote, unlike quarter 3, where I suggested to you skip all of those things. But I think here it was important, as I said. Honorable members, this is the time for your inputs, your suggestions, your solutions, your advice, your discussions, your arguments, all of those things included. I have many of my own. So shall I just start from one end because everybody might have input, or do you want to raise your hand? Shall I just start from here? Honorable Debor, we'll start with you. Anything from yourself? Come back to you. Okay, not ready at the moment. You want to take a 5-minute stretch or something? Stretch. Honorable Marvin Bella, over to you.
Thank you very much, Chairperson. We welcome the report that has been presented by the department before us, starting from the remarks that have been made by the MEC and all the reports that have been presented. I've got just few questions or recommendations to make, Chair. I will just talk. They will just pick up which relevant document I am talking to, because they've presented about number of documents before us. Chair, the department had underspent on the machinery and equipment about plus 100 million. So when it is compared to the benchmark of 75%. So I am checking with the department how this underspending in machinery and equipment affects the overall functioning of the department and the impact it has on the staff ability to effectively fulfill their duties. The second concern, Chair. Yes, Chair.
You want to ask all your questions? You want an answer now? A question.
So that you can save time, Chair, I'd rather ask all my questions so that when they respond to all my questions. Because some of my questions, some are not questions, are matters of are comments, rather. So I'd rather do everything once and allow the department to respond, Chair, if you allow that.
Your time,
Okay.
remember, I'm just checking.
It's my time.
It's your
Okay, so we can stay here until 10 o'clock. Hey, when ukhathazi konje
the food is there.
konje uqedile look faster Sasha.
The food is there.
Hey, Sasha, shwe.
The food is there.
The other issue, Chair, that I want to check with the department, in my little understanding, is that the financials and non-financial must tally. So when they are not tallying, it means the departments, there is something that they are not doing well. So what are the plans in place in order to make the financial and non-financial speak to each other? Let me put my question like that, Chair. I think I will rephrase if it is not understood well. The very last one, Chair, is the issue of the transfers to the municipalities, eThekwini in particular. I think it was raised in the previous reports that were sent before us. So I just want to check whether the department is still experiencing the same, and if so, what is the plan in place to curb that? Let me stop there. Thank you, Chair.
Thank you. MEC and Acting HOD, will you direct who will respond to those questions? Can you respond to them now? CFO, over to you.
Thank you. The impact of underspending on machinery and equipment. This was to defray spend so that we are able to meet other pressures, particularly compensation of employees. The underspend was not talking to repairs and maintenance of broken down machinery or non-replacement of equipment that requires replacement. It was more of deferring some scheduled maintenance. But then their equipment and machinery continues to work. The budget is aligned to the APP. So you have your vision and mission, you have your goals as a department, your targets, your annual performance plan, your strategy, and then how are you going to achieve your strategy is detailed in our plans, and then it's costed to then tie to the budget. Of course, our wishes are beyond the 56.2 billion, but then we had to then prioritize and link it to that. Thank you.
Thank you, Chair. Maybe firstly to add to the tallying of the financials and non-financials to CFO, the department has commenced a budgeting process that is the zero-based budgeting, where we are trying our best to do activity costing so that for all the activities that are undertaken at facility level, those activities are costed so that they are aligned to the package of services and ultimately aligned to the departmental operational plans, as explained. In terms of the transfers to eThekwini municipality, we must say, Honorable Chair and Honorable Members, this does continue to be a challenge because the processes that needs to take place in order for municipality to submit the claim, we are required to verify the claim, particularly in terms of the staffing, so that we are sure that the staff that we pay and the staff that are on the list in terms of the transfer agreement does take some time. And also in this past financial year, when we were concluding the transfer agreement, there was a lot of engagement around the funding that a municipality requires us in order to fully fund the personal health services, because there is a portion that is paid by municipality and there's a portion Department of Health pays about 65 to 75% of the budget that is required to run municipal services. A municipality pays around 35 to 40%. However, the leadership of the municipality has felt that this is an unfunded mandate for the municipality, which is true, and have proposed that we provincialize the municipal health services. However, because of the current constraints that the department is undergoing, we are not yet there. So there has been a lot of toing and froing in terms of actually concluding the payments because they complain of limited budget. Thanks, Chair.
Marvin Bella, any follow-ups? Sorry, MC.
No, thank you, Chair. I think there's just one part that the department forgot, underspending on equipment and machineries, that it was also part of the cost-saving plan that we implemented during the year. When during the financial year, we foresaw that we were going to overspend by 4.7 billion rands, we needed to sit down and have a cost-saving plan. And part of the cost-saving plan was to stop buying in some areas, including equipment and machinery. So I thought we just needed to clear that, Chair. Thanks.
Honorable Marvin Bella, you covered. Okay, I have some follow-ups. So first, I don't expect the response now, but when you cut back on machinery and equipment, it can have some catastrophic effects down the line. So can you send us a report of sorts to say where you cut, so that we can monitor that and see what it was? Number two, on the transfers to the municipality, I was interested to hear that the department is subsidizing that up to 75%. You said no. What was it that? Can you give clarity on that?
The department chair is subsidizing up to about 60% and the 40% transfer.
60%.
Yes.
So is it possible for the department then to under these very difficult budgetary constraints, think of, say, a period of time when one of two things need to happen. Either we take them over a period of 2 years, look at the MTF and say, look, 60% we need to fund the other 40% from of the baseline, or suggest to them they're complaining that it's an unfunded mandate, we don't have enough money, and these facilities are running to the ground to the extent that they may become capital projects, shut them down.
Thank you, Chair. Yes, the department has embarked on a phased-in approach in terms of the takeover of municipal health services, such that we took over Cato Manor, completely Cato Manor CHC is now fully provincialized. We identified 6 clinics that we were going to take over the following year. However, we then had these budget cuts and we could not take them on. And in the subsequent years also, we're going to identify maybe 10 or 15 clinics, such that we even had a plan that was going to take about 3 to 5 years for the complete provincialization. But that plan was then hindered by unavailability of funds, even because even if you take a few staff, MEC even had directed that maybe even to ensure that when we take over these clinics, we don't have challenges of human resource and infrastructure, that when we take over, we don't take the staff, but we move them to the clinics that are still within the, so that by the time we take them over, those clinics would have adequate staffing. MEC committed to actually including municipal clinics to the infrastructure plan of the department, because one of the challenges with municipal clinics is that most of their clinics were not custom built to be clinics. So there is a lot of infrastructure upgrades that would be required. Some of them are located in Sizakala centers or in libraries, in park homes. So if we include those in our annual infrastructure plan, we would be able to plan and budget for them in time. However, all those plans were thwarted by our financial constraints.
Oh, okay. I think let's do this. Seems like quite a complex thing. Especially those park home ones and the ones that, then you need to embark on a process of, really rationalizing services. So would it be possible at some point for us to have a discussion around it, that you bring to us what you have been discussing? Because here we're here to talk about the budget and not transfers and not the problem itself. So can you come back to us at a later point? We'll give you some time and then we engage on it. Can we resolve to the honorable members to receive that report? Honorable Marvin Bella, you and then MEC. Let's take Honorable Marvin Bella first.
Chair, on top of what we are resolving, I think our focus must not mainly be in eThekwini, must also include Umgungundlovu. I think Umgungundlovu has got the similar issues. If they are bringing in that report or that discussion, it must also bring in Umgungundlovu.
I think before the MEC comes in, thank you for that, because I think they do have one clinic here in somewhere. There is one clinic. Maybe no. So okay.
If I may just come in, Chair, the provincial government years ago was instructed to provincialize all clinics, 2014. And it was done everywhere except eThekwini, because eThekwini as a municipality was not a willing partner. in that provincialization process. Umgungundlovu and eThekwini were the biggest municipalities with clinics. So Umgungundlovu handed them over, and over the years, the department was able to then take over. I think the last one that was was provincialized is the one that is next to the Premier's office. City Central. Yeah. So that was the last one that was provincialized in. Then eThekwini, there was always a back and forth on the provincial government not being on the same understanding with the municipality until in 2019 I had a meeting with the member, the executive, the ESCO member responsible. And after sitting down, we then agreed. But I realized what was pushing them was that they were also feeling the pressure that it was an unfunded mandate suddenly, and they now wanted to hand it over. So we did have a proper plan, like Mrs. Msimango is saying, and our plan was saying we will not be able to take over once, but we will do it annually, and it was about 5 years plan that we had, and we did start with Ketomen. Now, the biggest problem, Chair, we will provide the report. I think I must start. They will provide the report and will assist us in discussing. But the biggest problem is that once you provincialize, or when you start provincializing facilities in eThekwini according to the health standards, most of them would be as good as us starting afresh, building new clinics. But more than 60% of them are in park homes. More than 60% of them are park homes. 25% are in Sizakala centers. Others, they just took someone's house and converted a 4-room. And, so majority of them, when we say we are provincializing, in essence, will be building new clinics, which is why we then considered to say, look, when we provincialize, we will then take the health workers that are there, put them in the nearest clinic, and then put that as part of the plan, because we might not be able to rebuild all the clinics that they have established, but we might be able to build 3 or 4 or 5, depending on our needs. But Chair, I welcome the report and the discussion that we will have.
Thank you very much. I think the MEC has raised another important point. I think when we have this discussion, we can't have that discussion amongst ourselves. So can we then also invite the EXCO member responsible for the city as part of that discussion? It will be a discussion so that we can chart a way forward and agree on way forward. So can we just include that? Thank you very much. Next, honorable member. Honorable Kwanyana.
Thank you, Chair. Greetings again and everybody in the house. Chairperson, I think I'm covered about that issue I've been talking about, but there are some other things that I need to clarify, maybe to the MEC or to the department. Chairperson, I want to be clear about the paying of invoices within 30 days to the service providers. I understand to our last meeting, they say they are going to extend the days up to 60 days. Are they winning for it? Or the service providers don't like to be extended to 60 days? I just want to be clear on that. Secondly, Chairperson, we talk about the patient safety. If we talk about patient safety, there were no explanation of on what, because I think some of the patients now they mix the patients in the wards in other hospitals, like the patients who are med patients with the normal patients. I understand. I think it's 1 month or 1 month and some weeks ago where we hear the report that one of the patients in the ward killed the other one. How do you going to stay away on that and allocate the patients according to their illnesses, not to mix the patients in the wards? Thirdly, Chairperson, we talked about the early pregnancy of children 10 to 14 giving birth at the early stage. I understand the MEC went to some of the hospitals in KZN and discovered that a 14-year child has been given a birth. In other provinces, they've been talking about implements to the schools, to the various schools. Now, I just want to hear from us here in KZN that do we have that plan to go to schools, put an implement to the children, because these social ills are killing us. How can you keep quiet when a child of 10 years giving a birth? No, I don't think this is good for us. We must take a stand here also in KZN about those issues. Thank you, Chair.
Honorable Kwanyana sometimes can be naughty. Yes, and she has palmed off somebody to me who was stuck in the lift for 7 hours at Addington Hospital at one stage. It's a whole story. So I'm surprised she didn't mention it here today because it's a long standing story. Anyway, who's responding to that? HOD?
When we are talking about patient safety, maybe let me start in terms of the reporting. According to policy and procedures, any patient safety incident, say for instance, a patient has fallen out of bed, that incident must be reported within 24 hours, captured on the system so that it's known that this incident happened and then what were the interventions to prevent it in future. So in terms of reporting, what we are reporting here is the closure rate. How many of those incidences that happen in a hospital have been reported and closed within 24 hours? That's what we are reporting in terms of the report. Then in terms of what the honorable member is asking about the separation of mental health care users from other patients. At a district level hospital where there are no psychiatrists, any patient who shows signs of mental disturbance is regarded as a medical patient. And that patient would then be admitted in a medical ward, because in a district hospital, there are no psychiatric wards where there are specialists and so on, for 72 hours until such time that the doctors can exclude other causes of mental health condition. Because sometimes someone may have mental health signs and symptoms, and that person is not mentally ill. Either it was some core disturbance in his body, or there's substance abuse and so on and so on. However, what we have been doing is to ensure that those patients are excluded as quickly as possible. That also there is support from our regional hospitals in terms of making sure that patients with mental health conditions can be quickly moved to the appropriate hospitals, like your psychiatric hospitals. Honorable members will remember that we were on the processes of commissioning the additional beds at King Dinizulu to alleviate that problem of having patients who are now diagnosed with psychiatric problems or mental causes being then moved to a psychiatric hospital. However, we've put all systems in place to ensure that those patients are clinically managed, because the important thing is to provide proper and appropriate clinical management in terms of what do we call it, Dr. Mosh? Proper dosing, giving treatment, and ensure that the patients are not violent, and adhering to those guidelines in terms of how proper doses and treatment for patients are given so that they don't become violent. Thanks. And then in terms of the pregnancy, 10 to 14 years, we in KZN also are providing Implanon as a device to reduce pregnancy, what we call long-term contraceptive devices were provided. However, in terms of the Constitution, we cannot go to schools, honorable members, and start then just giving Implanon to learners. We have to get the consent of the parents. That is why through the government has come up with a teenage reduction strategy that includes government departments, education, health, so DSD and civil society, which would include school governing bodies, so that parents can come on board and actually be part of this intervention. Because it's not even about the implant, just the issue of sexual and reproductive health, distribution of condoms, educating learners about sexual health, HIV prevention, HIV testing, requires the consent of parents. So hence then we have this collaboration and sectoral collaboration with all sectors so that we all can agree on the appropriate response to this. So it's one of the things that we need to discuss with the parents and the caregivers to say they need to give consent, they need to educate even at a community level the importance of use of contraceptives so the department can give those to learners with consent. Thanks, Chair.
CFO.
Thank you. On the issue of paying within 30 days, it's legislated and prescribed. The negotiations started. Members need to note that we have thousands of suppliers, but we have targeted some. There is some degree of success. Then there are those who are prioritized because they are known to be notorious for downing tools, because as employers, they don't necessarily pay on to their employees if there are any delays in collecting from the department. Then there are those who are agreeable to extending. Some are within the same sector. I'm talking ITC and telecoms, for example. We know who can slap us with interest immediately. We know who can be patient for up to 60 days. But obviously, the strategy is to be when there is a need, maybe lean towards the lenient ones in terms of payment terms. It's not necessarily cutting costs, but it is managing cash flow position at any given point in time. So there is some degree of success. We can't be exhaustive.
I don't think that should have been said on record, but anyway, over to you, MEC.
But I think I also just want to indicate and agree with the CFO that some service providers agree when we engage, others do not. But we've also found that this engagement in particular has made us susceptible to be used in other areas as scapegoats, in that some service providers will not pay their employers and don't pay them for months at a time in other instances. And when they are asked why they are not paying, they say the department has not paid us in 2 months or 3 months. In other instances, it is true. We probably haven't paid them in 2 months. But in most instances, when we go back to our documentation, because that's what we've started doing now, we find out that no, actually this person was paid last month or was paid the month before that, but they themselves have just not paid the employer. So while it assisted us with dealing with cash flow, it has a bad side to it, in that employees find themselves sometimes at the receiving end of not being paid, even when the service provider would not have paid the employees anyway, because there are some service providers that are notorious for that anyway, regardless of whether the department pays them or not. There are some service providers that are notorious for not paying when they're supposed to pay employees. So now it becomes, the department must be able to understand, because in other instances, you have not paid. Other service providers have now found a way also of forcing department to pay them, even if it's not 30 days actually, by just withholding salaries from the staff and the staff doesn't go to work.
So the department is forced to come in there. But it's issues that we are dealing with, Chair. Thank you.
On the contraception issue, other than constitutional provisions, more particularly the Children's Act of Employment, prescribes when children can make decisions for themselves, and generally the age is the age of 12. But still, there's debate about whether parental involvement or not. So that remains a problem. The Department of Education, I think if we speak to the members who are on education and survey, that interaction about education, the spending of the HIV/AIDS grant from education side, and things like that with regards to that. And the bottom line is in this entire issue, I think the point was raised somewhere. It has to be a whole of society approach. So, it requires the religious leaders, Amakosi, SAPS, health, education, everybody. We went to a school in Amajuba, St. Bernard's, I think it was the school. We went there. In 1 year, they had 41 pregnancies, teenage pregnancies. And the former MEC, current chair of health, Dr. Romo, was there, and we're looking at solutions. And I chirped that part of the solution must be he must open a labor ward in that school. Because there were so many pregnancies in there. Yeah, but a year later, after a whole of society approach, when we went back to that school, it reduced to 2. So that, it's that kind of thing that needs to happen. I'm just saying. But any follow-ups from yourself with regards to the questions and responses?
Thank you, Chair. No, I'm clear now about the schools, because in my mind, I've got that before you do a thing to a child, get a consent from the mother or the guardian. But when it comes to other questions that I've asked about the patient safety, you know what? Sometimes you'll find the department swimming in some claims just because there's that negligence of the doctors and the nurses. There is that attitude of nurses and doctors towards patients. Then after that, you find the hospital being sued about other patients. Do we have some other claims now that should be paid based on that issue of negligence or somehow like that? Thank you.
Thank you, Chair. Yes, we do have medical legal claims that are ongoing. Some of them date back as far as 20 or 21 years ago. So there are those that are being processed right now, medical legal claims. And also there are also letters of demand from people who claim, but they are still being processed through the legal processes. They are, yes.
Any follow-up? Thank you. Say over to you.
Thank you very much, Chair. Greetings to the Honorable MEC, colleagues from the department, honorable members, and colleagues from the legislature. I think I have a very few comments and probably just one question, really. One is that I would like to commend the department on working on what they call e-health, and also noting that there are about 42, if I'm not mistaken, hospitals that are already practicing e-health, and the department has actually trained the people that are responsible for it. I think it is quite a very good move, and we hope that the department is going to continue working on it and involving more and more hospitals until maybe our hospitals are even paperless. Sometimes patients will come to a hospital, and instead of them being treated file, for a very long time, for like 30 minutes, they're looking for a particular file. But it's easy when they come, say their ID number, and then you can find a file on the system. It makes things easier. It also makes things easier for very sickly patients where the doctors will have to know what is the what are the previous diagnoses maybe, so that they are able to treat a patient better, knowing what is it, what were the previous diagnosis. Abo Kika, Dr. Kika would be needing that information. I think it's very important because some patients end up dying unnecessarily because the information is not too close. It takes time to get to the information. So I think eHealth is really here to liberate and assist us in hospitals, and we hope that even in deep rural areas, the department will be able to take it there. And also, recently, the KZN Department of Health has hosted other MECs and from other provinces on the TB and the Deputy President on the on the World TB Day. Now, I got a briefing. I don't know if it's true, Honorable MEC. Maybe you were in that team, you'd know that there is an instance where they were doing house visits, and one patient that the deputy president was supposed to visit ran away. I am citing this issue, Honorable Chair, because there is a serious there's a serious challenge when it comes to taking medication, particularly, unfortunately, it is facts that men in particular do not want to take their medication. And as a result, what the department is trying to do in terms of increasing lifespan is going to be quite difficult if you have people that run away when they are told that the department is coming to see them. So I think it is very important that we do not only work and when we got the report, I think one of the doctors was presenting that, I believe she's from the department, saying that during that week there are people that they were able to start immediately on medication, on TB medication, which is a very good thing, and we hope that the department is going to take it and move with it. And we do not do it for event purposes, but also we are told that South Africa has reached an 8 million mark on HIV and AIDS, so that there are 8 million or more people that are infected by HIV. We've seen how the department is trying through its campaigns to fight against the spread of HIV. We've seen billboards, very nicely written, Jazzy, Ugapi Ghosti. We've seen it, and I think it works because it's also eye-catching to particularly young people who are the ones that, as much as elders, are also sexually active, but probably once in a month. Uh, but it is important to know your people. It is important for the department to know what messages it's sending to which people, who are you targeting. It is very important, and I believe that shows that the department has been able to do its research. It knows exactly ukuthi isuke ikhuluma nabo bani. So I think it's very important that we continue with that, but also we've seen the department is doing something on advertisement or awareness of PrEP. There is a post today on social media that says all married women must take PrEP. I do not know why would we say that, but it's a view of someone who said that married men must not look at me like that. There is that view.
Honorable Chair, that all married women must take PrEP, but I think we must correct it.
I thought only Honorable Panyana was. Carry on.
I think we need to correct it also, and run the narrative correctly. That perhaps everyone who wants to stay HIV free must take PrEP, whether married or not. You'll remember Honorable Kika once fought about it in the chamber with Honorable Makubane. But I'm sure now he is willing because we've engaged him.
Honorable member, I'm going to ask you to round up on, because it's now going off the budget.
Thank you very much. No, I'm on APP.
APP, yeah,
Yes.
targets, yeah.
Yes, on the
Let's,
target.
let's
I'm right on the
let's
target.
land.
Yes. One before the last is the I will just these ones I will intertwine them, Honorable Chair, on women health. I think we must do more on women health. Women health awareness is very important. One question which, as I learned, Honorable Chair, I wanted to ask is, if we do have in KwaZulu-Natal public hospitals that perform certain surgeries for LGBTQIA plus communities, surgeries like your breast reduction, sex reassignment surgery, do we have hospitals that do that? And do we have Honorable Kika, do we have people that have been assisters who are part of the LGBTQIA plus community? Thank you.
I think your question is very valid. Not sure why you mentioned my name. I have no intention of anything, yes, but anyway. No, it's okay. But what we will do is, I think, as a direction to the MEC and department, there was a lot of advice given on the APP at targets by the honorable member. Take that on board, make note of it, and make it part of your considerations. But I think in terms of the last question, which was the only question, let me see over to you and you can direct to.
No, thank you very much, Chair. Chair, I just wanted to comment on two things. The first one is on the program that Honorable Member Mkiza is talking about. We have a program in the department that we call Test and Treat, which is both on TB and HIV. And we have found that it is quite effective. And I think that's what Honorable Dipuro and Joseph Chair that was suggesting, that we come to the sitting, and I'm going to take you up on that we come to a sitting and actually test everyone on the 5 million that we want to target for TB. So we have found that to be quite effective, and we will continue with that. I agree and support that. On the new messaging, Chair, I have to speak on this. You know, our messages are quite, they get me into trouble sometimes. But the reason why we got to this new kind of messaging, Chair, was when I met with the department, I said to them, the kind of messages that we have right now on HIV and AIDS are the same messages that we had when I was a teenager. Now, if you have the same messages now when I was a teenager, it means literally we are not talking to young people of today. So we then said to the I'll try not to. So we then said the messaging that we had is stale. We needed something that's relevant to young people. Young people of today speak a very different Tsotsitaal than the Tsotsitaal I used to speak. They speak a different language. I don't even know what that is, you know, and you need to be able to get to them and get them to understand. And I'm very happy that Honorable Member and Honorable Kiza raised the issue, because the team that is working on our messaging is actually in the house. So I'm glad that someone else is appreciating their work. More than myself. No, it's honorable. It's Mr. Hlongwane and Mr. Bapisa who actually are working on that. So we will continue with that kind of messaging. What it does, Chair, is that you put up one billboard.
You will get calls from old people complaining on what is this that you have written. You will get calls from middle-aged people like myself, not understanding where you want to go with this. You will get calls from young people saying, sister or mama, you know, this and that. And what I say every time someone comments about it is that the fact that we are talking about it, we have achieved what we wanted to achieve, because it means you have noted the message, you are listening to it, you are unhappy about it. It's okay, but it's not meant for you anyway. It's meant for the younger person, and the younger person gets to hear what we are saying. But Chair, we really appreciate that. Thank you.
So underneath your very catchy message, translate it for the whole people.
Okay.
The Honorable Good Doctor, and then followed by the other good doctor. Dr. Biela, Honorable Dr. Biela, over to you.
Oh, thank you, Honorable Chairperson.
Sorry, apologies, just hold on.
My question was not answered.
Oh, yes,
it was
your
only
question,
one.
Yes, only one question. Sorry, yes. Yes, for the LGBT.
Yeah, no, thank you, Chair. There are some operations that are done. An example that you made, like breast reductions, they still get done, but the criteria is very strict, and it's not done for cosmetic reasons. There has to be a medical underlying reason that gets to be done, not purely for cosmetic. As for the other surgical procedures in terms of sex change, and we haven't done any recently. There's still 2 hospitals that actively run clinics, both Ugosi Albert and Grace. But you would find that the cohort of patients that they have is an old cohort that has been in the program for a number of years and it's now being followed up. But to the best of my knowledge, we haven't done any new cases in the last year or 2. But the clinics still run at both, mainly at the 2 hospitals. There might be referrals from certain hospitals like Madani, but your basic would be Grace and Nkosi Albert, but they haven't done any new cases recently.
Are you covered?
Satisfied. Thank you.
Honorable Dr. Biela.
Thank you, Honorable Chairperson. Greetings to yourself and the Honorable MSc, Honorable members and colleagues from the department. Honorable Chair, I must first apologize for my late arrival. I was chairing the Portfolio Committee for Human Settlements. Chair, I decided that I will not ask any question given that I am relatively new in the portfolio. And so I've taught myself not to speak for the sake of speaking. I might just lose credibility if I don't say anything of substance. That being said, please allow me to acclimatize myself with the issues of the department. Thank you, Chair.
Honorable Doctor, I completely understand. You know, I was new at one point in this committee as well, many years ago. And I think that sometimes we need to ask those silly questions if they are considered silly by yourself. But it helps everybody to ask those questions because you must remember you're not the only new member. And some of us who think we are around for a long time also don't know everything. We have to learn. So I think it's important to ask questions, but I appreciate your sentiment. But please never feel that, you can't ask anything. We must ask. And sometimes it is not the questions that embarrass one, it's the responses. and that is what we need to look at. So yeah, let's move on. Honorable Dr. Mtetwa.
Thank you, Chair. MEC in the department. Being the last person or last honorable member, most of my things are covered, but I still can't help but have to say something, especially on the report. It's one what the department is doing with your mother and child. We are seeing 5 a stable part of the department, and it's good to see kukhona okuhamba kahle. So on that, we have going on the department. We are doing very well with obstetric part, mother and child. Obviously, there will always be room for improvement, but what we are doing is normal cool lock. And then if you funda core values with department as a reminder to us and the department: integrity, trustworthiness, open communication, accountability, continuous learning, consultation, commitment to quality, innovation, and social justice. I'm reading these things because if we funda a report layer, quarter 3, as much as I'm expecting that everyone should hang their dirty linen on the fence for the public to say, but you should know that you have dirty linen and you should deal with that dirty linen before it becomes a problem. And I would like to say that as a comment to the department to say, we should keep our house clean. We can't keep exposing ourselves with this negative unnecessarily. It's a very difficult department to run, got a lot of issues and a lot of things can easily go unnoticed. And one of the things Engi worried now, I'm worried about it because I'm just privileged. I still work. I can show up in the clinic, go to my private practice, and still come to legislature. So I have quite a broad view of a lot of things, from how the private sector is. If you go to a private sector, then how you come to your own practice and how you come to the Department of Health. There's a lot of discrepancies. When we have one of our core values of our plans, which we want to strive for quality healthcare for both the rich and the poor. And being here, we are advocating for the poor to say the standard of healthcare that they are receiving should come up. So having said that, then you will expect within our APP should be informed by our quarterly report. And then our budgeting should move towards supporting the new APP. You cannot say that if you are looking at EMS. If you understand what are the problems of EMS, you cannot say we are going any direction towards fixing that. If you look at our achievements, our targets, we failed 0. And if we understand why we fail and look at and project our solutions, the PPP as an option, what is going to be very expensive, because now you are going to be inviting a private sector to come and help you with service. And those guys, they see a department, they see a good opportunity to make money. And I can assure you, it has been happening in other provinces, it has happened in other provinces. Also open the gate for fraud and corruption and a whole lot of things. So that, as much as it's going to be a solution that we can look at, but it's going to be very costly for us. Then you come back to budgeting and you look at how much we've allocated to EMS in going towards the direction of having that. We are definitely not going to achieve anything there. You can be sure of that. Because if you look at how much our budget has increased, 200 million over last year, against the current problems that are there in the EMRS, they are not going to achieve anything. So we should have really, if we are just taking EMRS, we should have really doubled the allocation towards EMRS, find it somewhere else in the department where we can channel that money towards EMS. The other thing I'm worried about is we are very hopeful as a department with the e-health, as we see it as something that is going to solve our problems, you see, which is maybe true, but then the reality of e-health in the province. One, at what stage is it functional, the functionality? What can we do with the e-health? And what we still need to get for the e-health, we still need to get Telkom to provide learning, provide services, which we're looking at KZN, the infrastructure, the landscape of KZN, that becomes very expensive and probably going to be very difficult to achieve. And also time, it's not going to be something that we can achieve in the next 5 years and be at full running of e-health. So then we should be seeing the APP talking to us, showing us low-lying fruits in achieving what is currently our problems. But the APP is not talking like that. We are putting hope in these big things, which the reality of us, we don't have the money for that. We don't have enough money to get e-health on the ground. We don't have enough money to allocate to EMS. We don't have capacity. If you look at how much we are defending our medical legal cases, we are failing to defend any legal case. There's a lot of fraud there. We are not even able to identify the fraudulent activities happening with our medical legal department. So we're running a department in an opposite direction to what we are trying to achieve. It is said, Uguti, we don't want to take accountability when it comes to service providers who then do not want to offer service because they are not paid in time and they're not willing to give and wait for 60 days. Those service providers become a problem to the department. And there are service providers which we should classify as core or critical, people that we can't run without them. And we should be able to prioritize those service providers so that we don't find ourselves having issues where they don't want to offer their services. And as much as we give excuses, we do give a lot of excuses and blame service providers, blame suppliers, and blame a lot of things. But we should not shy away from the fact that we are partly responsible because if you look at our report, there's a lot of over expenditure. We don't have money. We're spending money that we don't have. And if we are looking at our budgeting, we're budgeting the same as we did in the last financial year. So I can almost tell you most of our problems are coming back to us just as they are, if not worse. So with that, I will also just to ask two questions. We have service providers that we have now deemed as notorious service providers because of how they deal with the department, be it they are harsh towards they are quick to put interest or they are rigid. They don't want to assist the department. The question is, what do we do as a department with those service providers? Can't we replace them? Can't we find options so that we don't suffer for what they are doing to the department? And then on the issue of PrEP, Honorable Mkhize, through you, Chair, it's a ticking time bomb. It's unfortunate that Desmond Tutu once said it and said, if we want to change this world, we need to change the morals of the people who are in this world. PrEP is not a solution. Actually, it's a ticking time bomb. We're going to have resistant HIV in no time because the people who are taking PrEP don't know how to take PrEP. They take PrEP for 7 days and stop and create. While it is the two drugs in PrEP are the main drugs also in the treatment. So once we have resistant, we are not going to be able to deal with it. So we should be trying by all means to get people away from PrEP and only be left for people who critically need PrEP, your rape victims and your discordant marriages, people who really cannot have other options. But I can't be a married man and say every woman who's married must take PrEP, and it's going to be a very dangerous practice. And if you go to Northdale today or yesterday, the issue of Honorable Nkwanyan of a mental health case, patient being violent and actually assaulting other patients in the ward, they don't have sedation. They didn't have sedation when we went there for oversight. So that's what happens. You find that you admitted a psych patient, which you should be sedating and keeping them sedated so that they're not violent. But it's often that we do not have sedation. We are out of serenades, we are out of decibel, and we can't even monitor them. So the fact that we can't sedate them and keep them calm while waiting for the 72 hours to get the test if they don't have a background medical condition for their problem, then we are going to sit with those problems like that. It is true, even in the private sector, we do not offer cosmetic surgery. So it is cosmetic sex change, it is cosmetic, classified as cosmetic for both private and public. So we are not going to do breast reduction unless there is a medical condition, overweight, creating problems, and in those cases we can modify. But for social reasons, we shouldn't even try to go that way because we don't have the money to do those things, and it's quite expensive, and it carries a lot of litigation for both the private sector, even us. So we can't be opening that door. Not yet. We are not. We wish to be there one day, but not in the next 20, 30 years. So I think we should not entertain that for now. Can I just stop there for now? Thank you.
Thank you, Member. In the MEC and department, those were largely comments. There were questions there. Before I hand over to the MEC and the department, the issue of land and connectivity, I must say that, it's not only the Department of Health that is dependent on this. Department of Education is another one. And the MEC will know from from interacting with a colleague in the cabinet from Public Works that they are working closely with certain cell phone companies to have this rolled out, particularly on school properties. So the schools will get income from renting out their property to them, but it will also help our rural clinics in terms of the connectivity, because once you have the towers in the area, connectivity is for everybody. So I just wanted to point that out. We've advised the department, MEC and acting HOD, about your e-filing and donor funding, but anyway, it's just a comment because we've advised you about that. And then what I would want and what emerges out of the medical legal discussion, I would want to see a report on this. And perhaps you can tell us about the functionality of the department's own ombuds office. This has been my long-standing fight with the department for many years about capacitating this office. So the department had an ombud who retired. Then there was a move to appoint somebody to fill that place temporarily with a clinician, and some movement with regards to the ombud in the department. If we can get some information on that, if you can come back to a meeting and just give us information. What is the budget for that office? Who is the responsible person? Does it still exist? I'm sure it does. And a little bit of movement on that office, because one of the areas of reducing medical legal claims is by ensuring patients' rights are upheld at every level. Secondly, to mediate. And the Office of the Health Ombud, like the National Ombud, greatly facilitates that process. And a lot of things get solved at that level. So perhaps if, as your part of your armamentarium in your fight against the unscrupulous people and so on and so forth, is to capacitate this office. Maybe it's a thought. Maybe you don't have to give an answer, but maybe you can come back to us and say, look, here's information, here's the report, this is what's going on. And I'm saying that I'm asking for it because of the interest of time. Otherwise, we're going to go into a whole other discussion. We're still not finished. Still got a few things to go through, so I'm just handing over. Honorable Tabor wanted to say something. So we'll let you deal with Honorable Tetwa's input, and then the Honorable two members that were allowed the opportunity first but said later. So now it's later, and I'm going to limit them now. No long comments. You ask your questions, and then that's it. MEC and Deepak.
Thank you very much, Chair. Chair, do we have an ombudsperson in the department who will provide a report? The law doesn't allow provinces to have ombudsmen. We were advised by National that there's only one in the country, and in provinces you have, they're called complaints management officers. So, but we do have. I think they're trying to streamline things, but we do have, and the HOD will be able to provide that report. Honorable Mtetwa, I had a lot of comments, made a lot of comments, Chair. I'm not going to respond to all of them, but I think it will be very amiss of me not to respond to some, because it gives them an impression that what the comments he made are actually correct. The first point is on issue of PrEP. Chair, if you go to all the messaging of the Department of Health, nothing says everyone must go on PrEP. Absolutely nothing. And our messaging strictly says all those who know and are aware that they are living risky lifestyles are encouraged to go on PrEP. And we even mention them when we give the message, whether it's messaging that's written down or it's messaging that we engage with people, we engage. If you don't trust your partner, you think your partner is sexually active and is not protecting you, and you are unable to stop your partner or insist on your partner utilizing protection or condom, then go on PrEP. If you are a sex worker, go on PrEP. So there are categories of people that we say must go on PrEP. There's no way where we can say everyone must go on PrEP, because I'm sure Honorable Mtetwa is aware that when PrEP came up was also initiated by scientists and doctors who have the same information that he has. So it's not true, Chair, that we sit here and we say everyone must go on PrEP, because we are very much aware of the resistance that might happen should people not be effectively utilizing PrEP, which is why we also have campaigns on when you come in and you want PrEP, we actually take you through step by step on how you should be able to utilize your PrEP. Prioritize service providers. The CFO did say this. The CFO indicated when he was making the presentation, Chair, that we don't, you even said that some of the things that he said he shouldn't have said, because he was speaking exactly towards that.
That's fine. Sure.
Yeah, but he was speaking exactly towards that, to say when we look at our service providers, we prioritize them, we categorize them, and we say who is providing a skill that is non-negotiable in the department. And those that are providing services that are non-negotiable are obviously prioritized. They are engaged at a different level. So that is something that we are doing definitely within the department. The last point I wanted to engage on, Chair, is the fact that we have not budgeted enough for EMS. It's true. We've not been able to do so in the last year. The MECs before me was not able to do so. The MEC before that MEC was unable to do so. And the department needs to sit down and then say, what is the best way forward? Because instead of us coming to the portfolio committee every day to say, whatever we are buying is not sufficient. Chair, with EMS, we need 1,100 vehicles. When if it's according to the norm, 1,100 vehicles at least. Now, in the past 5 years, we've not been able to buy more than 500 vehicles. But the MECs before me in the past 5 years were not able to buy more than 300 vehicles. Every year when we buy vehicles, the vehicles you buy, you think they are meant to add to the fleet, when in essence they replace the vehicles that are there. And this is a vicious cycle. That is why we then said we are going to have to come up with an alternative plan. I'm the first one, Chair, in the first portfolio committee when I spoke about PPP, to say we are very much aware that there are pros and cons to the PPP. That is why we are not going to just implement any and anyhow. We needed to go down and sit and look at which one of the PPPs has the less challenges in terms of implementation. Because if we were not going to, if we had not done that, I could have just easily spoken and said we are getting into a PPP and this is how it's going to be, and that's it. But we needed to look at everything. And I even said other provinces have implemented this PPP. So we are going to be going to all these provinces and look at what is it that they did, how they implemented, what were the challenges, and we take the best lesson out of that. It was me who said that in the portfolio committee. So I want to say, Chair, we are very much aware of the challenges, but the thing is, we can't come to the portfolio committee and throw our hands in the air and say we don't have money and we can't buy EMS. We can't. We are given a responsibility to manage, and this is what we are doing. Chair, members of the portfolio committee are given the budget in advance. And you have complained to me previously to say we don't give you enough time. And I've taken that to heart, Chair, and I agree with you. Now, the budget was given to members in advance, and the intention of engaging a budget, Chair, is for members to be able to say, you have only allocated 100 million rands to EMS. But in your whole budget, you have allocated 500 million rands to a district hospital that you should not have done so. Remove that 100,000 there, add to the 100,000 of EMS, then go buy more ambulances. That is what members should do, because that's the reason why we give you the budget in upfront, Chair. Let's not be general. Let's not play politics about important things. If you say to us, we've not allocated enough money in EMS, and you feel as a member that we have allocated monies where we shouldn't have, then you must tell us. And this is the platform, Chair, for us to do that. Thank you very much, Chair. Can I request the Chair, the HOD to respond to the other questions?
Thank you, Chair. Maybe I'm just going to comment on the issue of the e-health functionality. By saying sometimes you have to invest in initiatives that may seem to be expensive at that moment, but in the long term may yield bigger results and may save you millions of rands that you are currently investing, that you are currently spending on. That is the whole principle and foundation around e-health. That yes, e-health is currently going to be expensive, but when we invest in e-health, we're going to save on millions of rands on the medical legal claims that we are currently experiencing. We are going to reduce patient waiting times and improve patients' experience of care. We are going to actually improve in terms of quality of care, as one of the honorable members would say, because the medical records of patients are going to be easily available to any clinician or healthcare worker that requires them. And also to say the e-health KZN is a step ahead of the rest of the country because the digitization of patient records is now through the NHI, and one of the initiatives of the current phase of NHI in terms of implementing electronic medical records. So when National comes to KZN, National will find that KZN is now 10 steps ahead and will then have to actually follow what we are currently doing here. The initiatives that we've done to say we have actually scanned thousands of patients' records. They are already on the system. Will actually ensure that fewer patients, and in some of the hospitals, doctors are now able to actually just log onto the system, get a patient's file, capture the patient's clinical history and clinical treatment through the various modules onto the system. Thank you.
Just one correction. Whilst KwaZulu-Natal is progressing, others have also achieved it. So we just want to place that.
Do you want to mention?
No, I'm chairing the committee. In the debate, I'll mention it. So yeah, I'm chairing the committee. Yeah, I can't go down that road. I'll leave it to Honorable Tabor to say it. I'm chairing now, so I don't want to be like my previous chair. I'm going to ask Honorable Tabor and committee to be quick because I still have my input to me. And my input, I had a lot of questions that I marked. I'm not going to ask them because a significant amount has been covered. I will make remarks, and those remarks will then form part of my report to the House. Right, because I have to stand up in the House and give a report on this budget, 10 minutes. So if the honorable members will agree or disagree with my remarks at the end is another story, but what I will be saying will be what go to the House. Over to you on.
Thank you, Chair. I'll be very brief. I've just got two things, and I think they're more of suggestions than questions. I'm going to delve into the topic that is not quite unpopular with your Chair, and that's mental health and homelessness. I know when we were doing oversight at the hospitals, we saw quite a few homeless people in the hospital beds that were being treated by the department. And a lot of them were there because of their mental health issues. One had been beaten up by another one, and so in essence, a lot of patients that come with assault, a lot of the assault cases that end up in hospitals are as a result of mental health issues. And I think there needs to be some kind of session or communication between DSD and the Department of Health to actually sit and discuss how the department, how government are going to actually deal with mental health, because I'm sure everybody like myself, sees more and more mental health patients on the streets or standing on the street corners and begging, or living on the streets because they're not when they're at home, they're fine because there's someone to ensure that they're taking their medication, etc., etc. There's a lot I could say about it, but I think there needs to be some form of communication between health and DSD to actually attend to the mental health issue that we're facing, because I really think it's a serious problem. And then the other thing that I also feel that DSD and health need to talk about is the unwanted pregnancies and unwanted babies. When we discussed it in DSD, I did recommend that they actually target people that are in clinics that are there for postnatal care, with their pregnancies, so that they can actually come to clinics and speak to pregnant women about what options are available to them if they don't want the babies that they're actually pregnant with, because I think it's something that we don't talk enough about, and the result is, as we see all the time, with people discarding babies in the bins or on the side of the road. So that's just two things that I wanted to make suggestions where I think DSD and health need to come together and have discussions on how we're going to do it and how we're going to incorporate it in the budgets. Thank you, Chair.
Thank you very much. I think those were comments and suggestions. The Honorable Dabur said mental health is not something I like. No, that's not true. I could be regarded as a mental case myself. So, that's another story for another day. Honorable Committee.
Thank you very much, Chairperson. I would love to thank all the reports, all the presentations, and my comment is going to be, maybe first I would like to thank our MEC. Your last comment about what we should be doing in terms of the budget, it's very important. But I think the challenge that I can face when the budget comes, and then I'm having 1.9 million, and for an example, when the APP was presented, we were told by other things like maybe the fencing. I think the presenter was saying the fencing is no longer like, we're no longer saying there's fencing for this place and fencing for this place, but we're saying fencing one, Immediately when you are compounding, to say one fencing, then when I want to unpack the budget that I'm giving, I'm getting a problem. And if I am giving, for an example, when we talk about facilities and we're saying the infrastructure budget is so much, and I am not aware that maybe are we talking about King Edward or are we talking about Inkosi Albert? Because if I'm having that differentiation, I can be saying to UMC, please, can you leave the King Edward at the moment and then let us focus at Northdale Hospital? I think as much as work is fair enough, but I think it will be very, very important that we get somehow, Honorable Chairperson, the details so that we can be able to make recommendation. Because as it stands right now, with myself, maybe it's my lack of financial, but I think if I am able to be given something that is telling me that when we talk about the EMS, we're talking about the EMS in what areas and what budget is taken to Tugela and so on, then it is helping. If we are getting it, initially. The other thing that I will comment is the strategy. What is the strategy of the department to do the collections? Because I've seen that the collection of money owed to the department is not really, to the capacity. I know previous presentations, there was a lot that was spoken in terms of that, but I don't think where I'm sitting, I am clear enough, that are we really getting this money and so forth. So maybe Chairperson, because you have told me that I've got a little bit of time, I'll end there. Thank you so much, Amisi. Thanks.
Thank you. Before you come in, Miss, I just want to pick up the point of the budget. So what does the committee do? I think here 10, 11 months. And so in that time, you would have seen that quarterly reports are given to us. That's the one thing. Department is required to come and present those reports to us. You'll also see that we get regular budget updates. So we have a budget analyst there is. So we get regular updates of the budgets of the department. And it is during these times that I would advise you to ask those particular questions for those breakdowns, because it also then, it's a proposal that will come from yourself. For example, you just mentioned one now about EMS. So nothing stops you from making a proposal to the committee that we take a resolution to get a breakdown on where is the money being spent in terms of a particular aspect of something of the department. We all would want to know. So if you propose something, we're not going to shoot you down and say, you know what, don't ask this, ask it. The other options that you have, and the MEC, because I said I'm not going to ask my questions, so, please note that you're going to get a lot of parliamentary questions coming from me. So that is another tool that is available. If I can become a bit facetious about the next comment, but so be it. Caucuses receive a lot of money to make them optimal. Hire a researcher, and if you have one, then get another one. If it's not doing the job for you, and not doing enough for you, get another one, because some parties are larger than others and get more money. And so you can hire more researchers and then use those researchers to dig into those aspects. And then you are better empowered in your ability to bring things to the House and to the committee. So I'm saying that because I use my researchers, and nothing stops you from coming to the committee to say to the committee that, look, for example, EMS, and I'm dwelling on that example because you raised it. We have taken the subject so seriously that we have seen that we have made it a focus of ours. So nothing stops you from coming here and saying, look, I'd like this issue to be, let's dig into this a little bit. Let's get our teeth into this. So please feel free. You can always write to me and we can channel it through the channels and make it a resolution of the committee. We open to that from the committee side. So I've given you some advice. Don't respond. I don't want to respond. Yeah. I'm yeah. Yeah. Okay.
I think
Yeah. I've got your WhatsApps here. So we'll pick up on that. That's between us now. But let's hand over to the MEC and
Thank you very much, Chair. I think maybe to advise Honorable Gamet, it also helps that the questions you don't send them to Chair. You have a right to ask the MEC directly, so you put them there, so that, because in terms of the rules, once you've asked an MEC a question, the MEC has to respond, and they have to respond in a frank and that kind of approach. And you also have the right that when the MEC or an MEC has responded and you are not happy with the response, we then do a follow-up on that. So, but Chair, I like how Honorable Gamete was asking, because she's really saying how then do we work together moving forward. I also want to make a suggestion, Chair, to say members can go through our presentation now and the budget and how we've tabled it. If there is anything, one or two slides that they would like us to add next time when we do a presentation that will clarify some of the matters, we are more than happy to do so. So that honorable members, when they read the presentation on their own, they are not confused. They don't think that they must be calling anyone. So you amongst yourselves can agree, Chair, to say, right now the department does a presentation in this particular fashion, but we need the department to add on this and that and so forth, so that we are be able to engage. I think that will help us a lot. Yeah, and then Chair, you were saying as well that you get analysts from the from Treasury. Our final draft of government is submitted to Treasury by January, Mr. Shes. January, ne? By January, this presentation or this draft would have gone to Treasury. So in the meeting between February and March, members, if they have the right to call the chair to say, can we get Treasury to come talk to us about what we've been given, so that we get a sense. I'm just saying, Chair, so that maybe we are able to really engage properly on our presentation. Can I then request Umamu Simango to respond to the question?
Your mic,
please. We need to keep your one next week.
Yeah, I'll just respond to the question on the revenue collection strategy. We are busy with the strategy. It's going to be presented in our next MANCO, which will be sitting next week. So we've actually asked them to develop a revenue collection strategy for the department. Thanks.
So in other words, you don't have one.
Chair, we had a strategy and we realized that it's not working optimally. So we are revising our strategy.
All right, and I would have been surprised if you said you didn't have.
Yeah,
one. But we asked that question so that you tell us why. But anyway, honourable members, I'm going to summarize a few things. As you have been speaking, there are things that you have requested and asked for and suggestions that you made. Mr. Nyanela here has made note of those things, and we will ask the department for those things. I think there was a point that was raised by the Honorable Dr. Tetwa there about the vision and mission of the department. I think in the budgetary cycle, I think this, these are the slides that when you're going through in the APP, the chairperson will tell you skip them. But these are the most important slides. Although we tell you to skip it because we want to get to the meat of other things, this is actually what we will hold you to accountable. Your vision and mission, you tell us you're going to do something. That's what we're going to hold you accountable for. That is what your budget should center around. That is what we're going to, those are the questions we're going to ask you about. There are old budget cuts that are still carrying through, and the department has not completely recovered in our view from those historic budget cuts. Even though they are not there, they are there because even though there's no cut in this budget per se, as announced by the MEC the other day, the reality is that the historic problems that are accrued upon you, I think it was 60 billion over a number of years, all of that has piled up on you. Your wage agreement shortfalls have still not been addressed properly, and I think although you have presented to us today what you're going to do about it, clearly it is insufficient because of the history. The commitment by the National Department about, in terms of funding this will not be seen immediately. So it's going to come at some point. We don't know when the minister presents his budget, then we might hear. We all want to hear about the VAT, yeah, but we also want to hear about what is coming to the provinces, and then whether, as the MEC said at the get-go, about whether she's getting her doctors or not. So that remains a concern for the committee. Your overspend in 23-24, what was projected versus after a condonation process reduced, and we note that as something positive. Your COVID staff were unfunded, despite the pre-COVID staff, who some of them were, you had unfunded posts, and that remains a concern and a pressure upon you. And this will continue to have a pressure on you in the outer years of the MTEF as well. That also remains a concern for us. So with the various pressures that are on you, there is no position, we believe, for you to continue to appoint any other staff or fill vacancies, despite you having told us that you do want to start filling vacancies without any firm commitments of the budgetary process in that regard. So we would want to see that. So again, I want to emphasize a point that I made a little earlier. This is the first year where we're not seeing a cut, as we have seen over 10-year period, in the equitable share, and I think that must be welcome. In terms of donor funding, we have advised you to go and seek donor funding for the various things that you do need, and the point here particularly is around something I think the CFO raised in his presentation. So PEPFAR on its own, I think we're making an assumption. They've donated in or around 220 million rands worth of medicines to the department, which we don't know if it's still going to continue. I tried, and I'll place it on record, the back channels, because I spoke to the honorable members about this before, and I said that let's engage with PEPFAR. But we were unable to secure. We had secured a meeting with them, but for whatever reasons they had, at the 11th hour they said to us that they are unavailable to attend the meeting that we had at Clarewood Hospital before we went to the PPST that day. We had secured a meeting with them, but they were then unavailable. But for whatever reason it was, but we wanted to get their side of it. Where are they? But we believe that they do have their own issues at the moment. And until that resolves, I don't think that we have seen sufficient evidence in the budget to say that, concrete evidence to say that you will be able to overcome that amount of funding for those particular things. Notwithstanding the national minister's commitment to say that there will be no, he will tell you to self-fund, but he will tell you that, look, there's going to be no suffering. But look, we understand the politics of that. But I think that is left for the MEC to go back to that level, to the National Health Council, to Herminmec, wherever these discussions take place, and say, look, where are we with that? So that remains a concern for us. The NHI grant was cut, and this remains a concern. Maintenance and repair is quite a pendulous process. So, there has to be a time when you are on capital projects, and there has to be a time when you are busy in the maintenance cycle. And I'll say this because I said it in my SOPA debate, and I said it, and I'll bring it back here, that I still think that the department needs to maintain a greater emphasis on maintenance. And the reason I'm saying that we need to maintain a greater time on maintenance is because of our visits to facilities. I mean, you yourself visit facilities and see these things every day. I don't think you yourself can say that we are where we need to be in the maintenance cycle. So that is our concern, was raised in terms of maintenance by various members there. The problem is that if we don't continue that maintenance cycle, you're still going to have maintenance issues that are going to become capital projects. Give you an example or two examples here in this district. The HVAC systems at Gray's Hospital and North Dale Hospital. Just to give you an example. You don't have to respond to it, but I'm citing them as an example. So while we welcome the maintenance cycle that you've had and demonstrated in your budget so far, we encourage you to continue your maintenance cycle versus your capital projects, which need to be done anyway. So whilst we've observed that through the various presentations and analyses that we've had, that in the years to come, you are veering back to your capital projects. That is why we are advising you to probably go back to maintaining heaviness on the side of maintenance. Your overall expenditure by facilities need to be closely monitored. You did issue the G77 to curb that, and we have previously welcomed the G77, not everybody. But we, by majority, we did welcome it because although it is not ideal, it curbed over expenditure, which has come down from your projected 4.7 billion rands to what you are projecting now to overspend. And then there's still the condonation process that might bring that lower. But notwithstanding, the idea here is that those facilities that are identified as runaway in terms of the expenditure, those ones that we have interacted with, we have cautioned them about over expenditure, even if it's 1%. You add all those 1% up and, it amounts to billions. So those facilities need to be reined in. And in reining in those facilities, and the culprits have become obvious now with the issue of the medicine stockouts that have been on the table. The facilities that are defaulters are the very facilities that have been overspending. And you need to use, for the lack of a better term to use, you need to use a big stick approach, MC. You need to wallop them. I mean, if that's not going to happen, then there's going to be a problem. The health is the biggest contributor in terms of over expenditure in the province. This remains a concern. Of the five, initially the province was expecting to overspend by 9 billion rands, in its deficit. It's come down in terms of the MEC's presentation to 5 billion rand. Of that 5 billion rand, 3.7 billion rand alone came from health. So it has to be a concern for us. One advice that we would give you guys, and although it happens a little bit late, human settlements capitalizes on this, but health doesn't. There is under expenditure in other provinces. There are lots of provinces that underspend on many things. You need to get your share of that money. It's come to health, KwaZulu-Natal, because especially in grant funding, they are largely incentive based, and you are spending your grant funding. That is commendable. So how can you go and get more from other provinces that are underspending is something that we would want you to see. Is it an emergency? Oh, whose blood sugar levels are low? So through that DORA process, through the accounting officers, CFO and your team, go and snatch that money up, because if you're not, it's our disadvantage. Because we are spending and they are not. And we would want to see, we don't know, and this is probably the one question I might have that needs to come out of this. What would be the standard on infrastructure spend? Is there, in municipalities, they say you must spend 8% of your budget. Is there a standard across departments? I don't know. If you want to answer now, otherwise you can talk to me later.
Sorry, Chair.
Yes.
My sincere apologies, Chair, for rudely interrupting. the Honorable Kwanyana was indicating that she does not have accommodation, so she might struggle to drive late in the evening. It's just indicating.
Okay. All right. Thank you. We can take that offline. We'll have it looked at. But thank you very much. That is a very polite way of telling me to shut up. But we know the Dr. Biela to be very polite. But that was my last point, honorable members. So thank you very much. Yeah, yes.
No, apologies, Chair. Just 1 point. On the issue of PEPFAR, we don't receive any medication from PEPFAR. What they do, and it's a result of an agreement over the years, they fund some of the services. For instance, where we run out of health workers, whether it's a nurse, it's an admin clerk, or a outreach team, then they're able to give us a few here and there. In the last meeting, well, not the last meeting, the first meeting when we talked about EPEPA, I indicated that if this continues, we will lose about 4,000 staff members generally. So they pay for the staff members, they pay for some equipment. For instance, they've bought us mobile clinics, they've bought us some mobile units that we utilize. They also pay for IT system, not through us as the province, through national. The IT system that is utilized by CCMDD, where a patient is informed that your medication is available, come and pick it up and so forth. That is paid for by those. So in terms of medication, we get our medication directly from national and through the allocation, but the areas where there'll be problematic is those.
Forgive me, I should have rephrased that. It is, I made a note here. I think it's ill phrased. I meant the input from which the department benefits. Okay. So that would have an impact on you, because you now have to find that. Oh. So that's what I meant. So I hope that resolves that. Honourable members, I think we've concluded that part of the agenda. So discussions, resolutions, all that are now covered. We now move on to the adoption and voting process. The adoption voting process is like this. It is per member the vote. We will go member per member. We will take a vote from you in support, against, abstain, whatever you want to do. What I just want to check is that is everybody here who needs to be here? Right, everybody's here. There is a quorum. All right, we'll start with the Honorable De Boer, and what we will need to state for the record is whether you support the APP and the budget. You have all made your inputs, and then we now at that point. So Honorable De Boer, we'll start with you for the record, your name, and then your vote. And then we'll note it and then tally the votes at the end.
Thank you, Chair. Chantal De Boer, I support the APP and the budget. Thank you, Chair.
Honorable Committee.
Honorable Patience Committee, I don't support the budget and APP.
I thank you, goodness, Lindile Mavembela of the African National Congress, support the APP and the budget.
Chair,
Please, goodness, Steve.
I support the budget and the APP.
I know your name, the record doesn't know. The record doesn't know your name. But anyway, it's the Honorable Kwanyana.
Thanks, Chair Sizopila Mkhize of the ANC. Do support the APP and the budget.
The Honorable Doctor.
Thanks, Honorable Chair. Andy Lebiela. I'm in support of both the APP and the budget. Thank you.
Next Honorable Member.
Honorable Pikeleli Tetwa, I'm not in support of both the APP and the budget.
I will cast my vote, and my vote is I'm Imran Kika. and I'm in support of the APP and the budget. Are there any honorable members online? No honorable members online. That concludes the voting. Can I have the tally of votes? Can we have the result read into the record?
Thank you, Chairperson. 6 support and 2 do not support the budget and APP. Thank you.
I confirm that that is the result, and therefore the budget and APP are approved by the Health Portfolio Committee and therefore adopted. Thank you very much for that process. Well done to the honorable members on that. Honorable members, we now move on to item 10 very swiftly. Honorable members, we may want to do this today, or we may want to defer it to another, but I will tell you why this is on the agenda. The rules provide for us to establish subcommittees of the Health Portfolio Committee, and more particularly for a particular focus. There are times from time to time things that arise, and I thought that we would want to, as part of our FIS, our Focus Intervention Study, which is EMS, I thought that we would want to benchmark. We would probably want to look at what are good practices out there, and also look at what are not good practices out there. So for that purpose, we said it is best to go and visit those places where there's good and bad practice, but I didn't want that to be something that is deliberated over by the entire committee. Rather, we give that to a subcommittee to have all the deliberations. So in terms of the rules, we establish a subcommittee, give the subcommittee a mandate. They will elect a convener of that committee when they first meet. Once the convener of that committee is elected when they meet, then they can have the deliberations according to the decision of the main committee, and that is this one. And thereafter, they deliberate, and we give them a time period. And after that time period, you report back on the outcome, and then we look at that, and then we adopt it. Either we agree or disagree as a whole. Ideally, what I had in my mind was a 4-member committee, one from each political party, the IFP, the ANC, the DA, and MKP. We have 1 member from each, and then we move from there. Who those members may be that we elect to that committee, perhaps we can either take direction from the legal advisor, whether we do that right now, or we take input from the parties after they have had their discussions amongst themselves, but we resolve to form the committee today. That is the proposal I put to you. Anybody objecting to the support? Yes, Honorable, please.
I will chair. Thanks. I want to propose that we defer this election of a 4-member committee. Also, because the Honorable Chair, I think you'll know that as we are seated here doing our work as committee members of this portfolio committee, we are sent here by parties. And how we operate, our parties need to know and be informed, and they take a decision on who goes where. So I think because we don't have a party line, Chair, we defer it. Thank you.
Is there support for that?
Yes, I can support.
Support? Anybody opposed to the motion? So noted that the MK supports it. All right, look, I'm not averse to it. I'm not averse to a decision today. But you know, I do get I don't like taking things off the agenda, because this item was on the agenda at the beginning that people proposed and accepted. It is also something that was circulated before. I'll come back to about Bella, your hand is noted. So I'm not averse to it. There's a vote already taken. I'm now just giving an opinion. So I'm not averse to it. You can go and come back, but before I take Honorable Mavimbella's hand, I've been just advised by the legal advisor that I can't, the one from each party can't be. It must be a proportionate representation in terms of the rules, and so we'll do that. So let's do that. Let's go back to our parties, tell them this is what we want to do. We want to establish a subcommittee. It is for the committee to decide, but if you want a mandate from your party, good and well, you go and get it and come back. So we'll bring it back. There is a vote against that item. We should have then, bring it back to it's deferred to the next meeting. Then we move on. Honorable Mavimbela had something to say.
I think, Chair, I've been covered because you have the view of the legal advisor. Because I was going to amend what my colleagues were saying. We are not removing the item from the agenda, but we want to get the mandate from our parties. We are taking the principle that we will establish the committee, but who is going to that committee will be advised by our political parties. I think that's why we're deliberating on the matter.
Thank you, Honourable Member. Done and dusted. Item number 11, I'm tabling the reports on the festive season report, stakeholder engagement session report, Northdale Hospital, East Boom, CHC, and actually this is not Fort Napier, but Peter Maritzburg Forensic Pathology Services. I'm tabling those reports that were already sent to you, and we need to adopt those reports. As the committee reports, the department, I'm informed, has been, the resolutions taken by the committee in all these reports were sent to the department. We will expect a response to all of those at our next meeting. Timelines were there, but because the timelines of the programming committee are also not conjoined, I think we'll receive them in the next meeting. Also, in your responses before I close the meeting, we'll have a mover and seconder just now. There are lots of other things that we sent to the department that we didn't get responses to. We'll follow up with those with the MEC and the acting HOD. May I have, for the adoption of these reports, mover and seconder, Honorable Bavimbela?
Honorable Chair, we want to support this report as our reports as this committee because we were doing exercise ourselves.
Thank you, Honorable Mavimbela. Anybody seconds? Honorable De Boer, for the record, please.
Thank you, Chair. I second.
So seconded. Any objections? None. The reports are therefore tabled and therefore and duly adopted. Thank you very much. It's been a marathon meeting, honorable members. Honorable Gwanyana's request can be dealt with by our support staff and officials. Having said that, for those that are traveling, safe journey. Thank you very much to you, MEC and acting HOD and your team for honoring us with your presence and being here. We do note that you didn't come to our meeting on Friday, but anyway, we didn't have one because you apologized. You had to be at the G20 and all kinds of things. But anyway, these things happen. Thank you very much for your time. The meeting is therefore closed and adjourned.
Honorable members, there is lunch. Dinner, I'm sorry, dinner.